Three, two, one. We are live now.
Good afternoon, everybody. Myself, Dr. Vishal Dave, Medical Advisor at Intas Pharmaceuticals. I welcome you all for this Perfection Series Season 10 on the topic Thin Endometrium, Deciphered. It's my privilege to introduce co-convener of this Perfection Series, Dr. Monica Jindal Singh. She is Honorary Secretary of MP Chapter ISAR. She is Vice President of Bhopal Obstetric and Gynec Society and Bhopal Menopause Society. She was Organizing Secretary of 27th Annual ISAR Conference 2023 held at Bhopal. She is also the founder and convener of Oxy Symbiosis series. Over to you, madam.
Thank you, Dr. Vishal, for the kind introduction. And without further ado, we proceed with thin endometrium, which is I think, the mother of all disorders as far as ART is concerned, because whatever you do, you have to ultimately look for a good endometrium. And I cannot proceed without thanking ISAR President, Madam Nandita Palshetkar, who would be joining, I think, for a couple of minutes to bless us. And who all over India, we know her as a very dynamic president who has taken ISAR forward in many fold directions with her vision, with her acumen, with her intelligence, and with her charm. Thank you, ma'am, for this honor, and thank you for your permission given to take ISAR Perfection series forward. Next, I would like to invite and thank our Secretary General, Dr. Sujata Kar, who is at present very busy organizing one of the greatest conferences of the year, which fertility specialists attend and look forward to. That is Indian Society of Assisted Reproduction 28th annual event at Bhubaneswar. So she definitely has got lots in her hands, but she is a very good mentor to us, a very supportive senior who is a keen academician, a researcher, awarded so many awards from Orissa government, a very good writer, and basically a very nice human being. I thank Sujata ma'am also. Next, I would like to... Nandita ma'am has come. Good evening, ma'am. Good evening, ma'am. Can we have Nandita ma'am?
Hi, evening.
Good evening, ma'am.
Hi,
Good
Good evening, ma'am.
Good evening,
ma'am. So nice
Hello.
of you to join, ma'am. Seeing you after such a long time.
I know.
Ma'am, everybody from Perfection is here, and we have our guests of honor, Dr. Reddy and Dr. Durusha is there as chief guest. Dr. Rishma Pai is also chief guest as well as speaker. And Padma Rekha Jirge madam is there as guest of honor. So please oblige us with a few words of your blessings, ma'am.
Thank you, Monica. Monica, first of all, congratulations on your Perfection series. I think it's fantastic. It's really good. And the way you've been taking it all across, and it being the 10th series of this year, I think it's really in a short while. And you've covered such fabulous topics. I think that's really, really great. And I'm very happy to have you on my team, such a hardworking person, and with the Bhopal conference done so beautifully. I'm looking forward to, in fact, Sujata doing a great conference. And I can see all my friends. I think very happy to have Sanjeeva Reddy and Dr. Dhrusha as the guests in your Perfection series, and all the best to you. And I'm sure I can see Vishal, KC, Purnima is here. Of course, she called me. Randhir is there.
Yes, ma'am.
Seema, how are you? All the best. Randhir, all the best. And you too,
Thank you.
Monica,
Thank
all
you.
the best.
Thank you, ma'am.
Hello, Madam Dr. Dharusha. I think that's really great to see you. And I'm happy that you've accepted our convocation request. Kalpana, good to see you. Then there's Manisha, Monica, who is Rishma is there, Tindu. And I think that's it. So I'm glad to be here. And thin endometrium is something that is really troubling all of us. And we really want to know what is the evidence-based treatment. I think there are lots of treatments available. Practically, we do something else. Evidence says something else. And I think to throw light, you have a fabulous faculty, and all the best. And hope to see you all in ISAR soon. And all the best to all those who are contesting in the elections. I'm sure you all will do well. And this time's elections are really prove the fact that ISAR is becoming so popular that
Yes, ma'am.
everybody wants to be part of it. It's become very vibrant, and I'm really happy that I'm handing over such a vibrant society to Amit this year. Thank you. Thank you, Monica, and all the best. All the best.
And ma'am,
Thank you.
80% of the popularity of ISAR is because of Nandita ma'am.
Yes.
Thank you. Thank you.
Thank you, ma'am. Thank you.
So
Thank
you
you.
have really made it very charming and very easy to work with, ma'am. So I think people want to join with you. People want to come to ISAR. People want to go back to ISAR, and
And yeah,
that's
and,
just
and
because
Monica,
of,
and Monica, nowadays the people are coming a bigger organization of Foxy towards to ISAR also. So now it has got a feather diamond.
Yes,
Yes.
I'm glad. I'm glad. I'm glad.
Yes, ma'am.
So now we, ma'am, with your permission, can I read the CVs, invite the chief guests and
Yeah, please, please go ahead.
guest.
I'm in a meeting, so I'm going to go. Okay, thank you. Thank
Okay,
you.
ma'am. Thank you so
Thank
much.
you, ma'am.
Thank you
Thank you,
so
ma'am.
much
Thank
for
you, ma'am.
your.
Thank you, ma'am.
Thank you, ma'am. I would also like to thank Dr. Sunita Tundalwadkar, our Vice President, ISAR, and Madam is also the convener of ISAR Perfection Series. And she would be, I think, joining us for a couple of minutes very soon. It is because of her, after Bhopal ISAR, that we, conceived actually the ISAR Perfection Series, and it implanted very well. And it has now become full term. And so, in fact, yesterday I got a message from Dr. Amit Patki, incoming president of ISAR, that Monica, can you prepare a PowerPoint presentation of ISAR Perfection for presentation in ISAR Bhubaneswar? So I was so proud of it that this is going to be one of the agenda for the managing committee in ISAR Bhubaneswar. Thank you so much. And now I would like to move to our chief guest for today. Rishma ma'am, good evening. Durusha ma'am, good evening. I think Rishma ma'am is also there. And I would like to have the series. Good evening, Rishma ma'am. And can I have the CV of chief guest, please? It's with a great happiness that I introduce our chief guest for today, Professor Dr. Durusha ma'am. And I have, got the opportunity of having her in our midst after a lot of persuasion, lot of emails, but ultimately I got through. So I'm so happy. And I would like to introduce her to the 10th webinar of ISAR Perfection Series. And Madam, I know, is a perfectionist. I've seen her work. I've seen the way she talks. She conducts so many the organizations she mentors and she holds together. Madam is Director, Gynec World, the Center for Women's Health and Fertility in Mumbai, the founder president of the PCOS Society of India, from where we receive such beautiful bulletins, flyers, and reading material. She is the chair of the Council of Affiliated Menopause Societies, chair of Metropolis Foundation, vice president and chair of Education Committee of Aspire, member of the Women's Health Vertical of C20 Government of India, the past president of Foxy, president of Indian Menopause Society, past chair of ICOG, and past president of ISAR. She is also been the member of Ethics Committee of the International Federation of Gynecology and Obstetrics for 6 years, Director of Digital Education, Chair of the IMPART program on the board of the International Menopause Society for 8 years. Madam has received grants, huge grants for her projects. And as president of the PCOS Society of India, Madam has created an awareness program on a very important health disorder called the PCOS, which affects women right from puberty to beyond menopause through a project called Vijeta, that is the winner. Madam is the immediate chair of Aspire Special Interest Group on Reproductive Endocrinology and PCOS, and she has also been the international advisor of ESHRE's Special Interest Group of Safety and Quality in ERT called SQUAT. Her chief areas of interest are reproductive endocrinology, of course, PCOS, and infertility. Madam has been the editorial board of various international and national journals, proud recipient of many orations, awards, and honors, the most prominent being the FIGO Distinguished Merit Award, being the first and the only Indian recipient of this prestigious award, and been conferred the honorary fellowship of RCOG, the Mahatma Award 2021 for Social Responsibilities and Gender Equality, and conferred the Lifetime Achievement Award for Excellence in the Field of Infertility and Women's Health, the iconic gynecologist and fertility expert by the Honorable Bhagat Singh Koshyari, Governor of Maharashtra, India. Madam, we are so proud to have you in our midst. Thank you so much for taking our invitation. And ma'am, please would like to have a few words from you now.
First of all, thank you very much for inviting me. I know you, I was dodging you for quite some time because honestly, this is the clinic time and I wanted to be sure what time I need to log in so that I don't keep my patients waiting, which I don't like doing. So thank you very much for giving me the specific time I should get in, and I truly appreciate it. So first of all, let me congratulate you all on this wonderful program which you've created. And this is session 10, I think you're doing, and it's amazing that you have been doing it for 3 hours at a time and doing excellent work. The fact that you're focusing on thin endometrium, as Nandita said, that it is so important, I totally agree. And most when PCOS, we do see a lot of thin endometrium coming up in these women. The receptivity is not the best in them. So in short, I think it's a topic which is of great interest to everyone. And the only thing I would like to say is that I see a lot of patients where, as there's enough evidence only for a certain number of products which we can use. Whilst there are many products available in the market for us to use for thin endometrium. The question is that what should we do is the dilemma. And I think if you could add on a little topic on, where ethical treatment is concerned in these areas which are debatable, I think it would be a good idea to do it. At ISAR, we had created an ethics committee and we have published 4 publications related to ethics in infertility. And one of them was related to HIV and management of infertility. We have talked about various ethical issues. If you look in the Journal of Human Reproduction, you will find that there have been 4 sort of committee, ethics committee opinions we have put across, which I think people should, think about doing whenever we are doing work. After all, we are creating babies and we are creating it for the future of mankind. If we are doing some harm to them, we do not know, because many of us are culprits in this whole field of ART, because we do use sometimes products which are not evidence-based. But it's a sign of desperation we have. We have a sign of desperation and we want the woman pregnant at any cost. And I think we need to be a little bit cautious about what we use. And that is the message I would give across to everyone, that especially in an area like thin endometrium, we tend to do a lot more than we do in other areas. So in short, I would say when people are desperate, say somebody has cancer and they are desperate, they are willing to do anything to save lives. I think that's what is the situation with ART. Anything to do with to get the pregnancy. So let's work together and do good work. And I suggest that we create some evidence-based studies ourselves through ISAR, and take ISAR further, much further than what it is today. Yes, I was the president maybe a few years ago. We started with a membership of only 800, and in 1 year we made it 1800. So it was good that so many people joined, and they continue joining. This course will go on and on, because you're having a lot of dynamic people coming in, and I see the whole lineage now. I mean, the people who are on your brochure, we have Nandita, we have Sunita, we have Amit, we have Sujata, we have all the dynamos just now, and I'm sure our organization will be much bigger than what it was. Thank you very much for having me, and I'm happy to talk to all of you. Wish you all the best for your session, and I will watch the program once I have seen I won't be able to see it now, but I'll see it later at some leisurely time. Thank you once more.
Thank you so much, ma'am.
Thank you, ma'am.
Thank you for those that great chief guest speech you have given us, and for your information, ma'am. The 1800 member force which you led with ISAR, now it is about 5,600 plus.
Yes.
And we will definitely see more members joining in Bhubaneswar. Conferences are one of the most greatest incentives where,
Yes.
juniors and colleagues, they join because they see you, they see the conference, they see the vibes, and they join. And Madam, you're very true in remarking that things like PGT, things like freeze all, things like ICSI for all, maybe are creating more problems than good in the long run. Now, with your permission, Durusha ma'am, I would like to invite Dr. Rishma Pai ma'am, who is again our chief guest for today, as well as our first speaker for today's webinar. And I would just like to introduce Rishma Pai, like she is the rainbow in the sky of Hisar. She's such a charming and such a colorful and lively person, and we love her so much, all of us. Madam has been treasurer IFFS, member of the FIGO Committee on Menstrual Disorders, former president of all the great bodies of India, FOXI, ISAR, IAGE, MOGS. She's consultant gynecologist and infertility specialist at the Leelavati Hinduja Jaslok Hospitals of Mumbai, has been the recipient of so many awards, like 2020 she received the Glorious Legend FOXI Award, 2019 she received the Business Leadership Summit Award, 2019 again she received Inspiring Gynecologist of Western India Award by Times of India, 2018 she was a recipient of Midday Health Wellness Award as icon in OBGY and infertility, 2017 recipient of Women Empowerment Award by IMA, 2017 recipient of RK HIV Research Center Award for Excellence in Medicine, 2017 recipient of Bharat Nirman Award for Women Entrepreneurship, 2017 recipient of 50 Outstanding Women in Healthcare Award, and 16 recipient of the Middle East Leadership Award. So she has been awarded from all corners of the world, as well as being the Woman Achiever, awarded the Newsmaker Best Doctor, Great Women Achievers Award for Excellence in Medical Field, Nav Shakti Award, Award for Distinguished Alumni awarded by Jai Hind College, Mumbai, has organized so many beautiful conferences, and we've recently witnessed Femtech 4 in Mumbai, which was again a class apart. Her conferences are full of greatest academics and greatest fellowships. She has given 70 orations, invited speaker at 450 national and international conferences, chapters in 63 books, and published 42 articles in leading journals and other publications. We are really honored to have you amongst us, Rishma ma'am, and we would like to have a few words from you, please.
Thank you. Thank you. Good evening to all of you. Thank you, Monica, for such an elaborate introduction. I tried twice to stop you in the middle, yes, but you didn't. So thank you. And really, you are one of those super warm, wonderful people. And that is why nobody ever says no to you. And all of us are here. Everybody whom you spoke to has, always agreed to be with you and with Randhir, because you all are not now, but over the years have been wonderful, warm, hospitable people. So thank you for inviting me, not only as a speaker, but also as one of your special guests. It truly is a matter of honor. I really believe that, it's really passion which drives perfection. And it's really like the pleasure you put in the job that, really gets perfection in the work. And that is why you people with passion and loving what you do are able to create this perfection series. And, all of us really, somehow I think the fact that we are doctors, the way we all are committed to our profession, all of us really do strive towards perfection in everything that we do. Perfection, of course, is extremely hard to achieve and probably impossible to get. And just for an example, the topic that you picked up today, endometrium, the thin endometrium, refractory endometrium, I think that's one of the single most frustrating entities that all of us deal with. And, we realize that we can't get perfection here, but we keep on striving, we keep on working towards it. And I think each one over here present today has this passion to learn, you're already so good, and yet you want to be part of this and achieve more and learn more. And, I really want here to say that I'm looking forward to meet all of you at the ISAR conference in just 2 weeks from now. And I want to already extend a warm invitation to all of you for the ESHRE ISAR IFS Fusion Conference that we're having in September 13 to 15 in Jaipur. It's going to be the first time that ESHRE is coming to India. We did try to do this a year or two earlier, and then COVID came. And so finally in September this year, the entire ESHRE team, there will be more than 20 ESHRE leadership coming here and hosting along with us a beautiful fusion conference. And that's why it's fusion, because it's all the ESHRE and ISAR and IFS coming together to present to you a beautiful conference. So look forward to seeing all of you there. Thank you for giving me this platform. I'm looking forward to our interactive session coming up now. And, let me just say that all successful people really learn that success is buried on the other side of frustration. So we'll go through the frustration of thin endometrium and we will all emerge successful on the other side. Thank you. Thank you so much.
Thank you so much, Rishma ma'am.
Thank
It was
you.
wonderful listening to you, and congratulations for getting this fusion conference of super international level to the Pink City. And we would definitely be there as part of the galaxy and enjoy the whole experience. And now I would request Dr. Vishal to please let me invite our guests of honor. Our first guest of honor is Dr. Sanjeeva Reddy from Chennai. Sir, we know, is a very academically inclined professor, OBGY. He is the professor in Department of Reproductive Medicine and Surgery in Sri Ramachandra Institute of Higher Education and Research in Chennai. And he was the first to start the super specialty course of MCH in reproductive medicine and surgery, first time in India, which must be so wide for by the students. He has been the recipient of special awards like Dr. B.C. Roy National Award in 2015 as an eminent medical teacher, which was presented by President of India himself. Distinguished Faculty Award 2020 from Srihar, Chennai. He has received the Champion of ISAR Award in ISAR 2020 Conference of Hyderabad, IVF Icon Award from Asia GCC, IVF Icon Award in Dubai, and the IVF Icon Award from Economic Times 2022. Sir is the expert panel member in the MCI to formulate the syllabus and minimum eligibility criteria for MCH in reproductive medicine and surgery course. He's also the specialist board member of reproductive medicine in NBE, New Delhi, expert member who prepares syllabus for the children and our students to follow. President TAPISAR or past President OGSSI, organizing secretary of several wonderful conferences we have witnessed in Chennai, of ISAR, AICOG also, Yuva ISAR, and Embryology ISAR. We welcome you, sir, Dr. Reddy, and we are waiting to hear from you as the guest of honor.
Thank you, Monica, for your kind introduction, and also for inviting me for this guest of honor for this series. You are lucky, and Dr. Nandita has selected you perfect person for perfect series as convener. Usually, only one person will be active, other person will be supportive. But here, both of you, Ranadir and both of you are very active. I don't know, you should tell me some.
Thank you, sir. Thank you, sir.
Okay. It's very nice. You are organizing 10th series. The endometrium is more, or endometrium, you can say, is most neglected. We have done a study on this in unsuspected patients, all infertility patients who have taken the biopsy and sent for CD138. 27% of patients is coming positive. And when we treated like that, the pregnancy rate is almost doubled. That is the importance of this one, but not many people are aware. Hope after listening to this webinar, tomorrow onwards, the way they are going to practice is going to be changed. Thank you for selecting this type of topic. It is going to be useful for every person who is practicing ART. Thank you for inviting me. I hope coming series also it will be very useful for the other people. Thank you, Monica.
Thank you, Dr. Reddy.
Thank
you.
Thank you, sir.
Dr.
Thank you, Sanjeev, sir.
Purnima.
Thank you.
It is really heartening to have professors, people who have started MCH in India, coming with us and speaking to us. It is so heartening, sir. And thank you for your presence. I would like to now introduce our guest of honor, Dr. Padma Rekha Jirge. So I am really privileged to have her amongst us. Madam, good evening. Because she has been the the focused person who has always published, who has always studied about research, taught about research, and reading Madam's CV, you all will realize why. She's the scientific director of Sushruth Assisted Conception Clinic and Shreyas Hospital, Kolhapur, and the founder director of Prismatic Research Foundation. She's the clinical research fellow in ART from the University of Glasgow, and currently, madam, see her passion. She's currently pursuing MSc Epidemiology from the University of Edinburgh. Her most recent publications have been latent genital tuberculosis, how it adversely affects ovarian reserve. And whenever I read about ovarian reserve, there are so many papers I write on ovarian reserve, always, her name flashes. Padma Rekha P.R. Jirge, it's always there in all the, whenever you Google search or go to PubMed. Resuming assisted reproduction services during COVID-19 pandemic, the initial Indian experience was again published by Madam in the JHRS 2020. She also wrote about association of AMHR2 gene polymorphisms with ovarian response and pregnancy outcome in Indian women, which must be a very interesting read. I'm yet to read it. Ovarian stimulation in assisted reproductive technology cycles for varied patient profiles and Indian perspective, again in JHRS 2022. Ethnic discordance in serum AMH in European healthy control, Indian healthy control, and Indian infertile women, a population study from India and Europe in RBM Online 2022. She has edited various academic publications, contributed to more than 20 textbook chapters. She is at present the chairperson of MSR 23 to 25, President-elect of Fertility Preservation Society of India 22 to 24, and Chairperson SIG Reproductive Endocrinology PCOS Society of India. She is immediate past editor-in-chief of JHRS and reviewer for fertility sterility, human fertility Cambridge, reproductive biology and endocrinology, JARG. Welcome, Padma ma'am, and we are waiting to hear from you now.
I think there have been a lot of motivating and factors said by, and we have learned about the guests so far, so I have very little to add. But very good evening, Monica and Randhir, a perfect combination for this ISAR Perfection series. And I think the whole program planned for this evening is just going to stimulate our thinking and encourage us to deal with this ethically and scientifically. Some of the challenges faced as far as endometrium is concerned, I think is very unique to countries like India, and we may not be able to get answers from the West for this. So we are in a very uniquely placed scenario where we can contribute very, very productively and meaningfully to this area to solve some of the frustrating problems. So as Dr. Drusha ma'am said, and as Rishma said, I think from frustration we are facing, let us say that we will create a story of success. And thanks for stimulating the thinking along those lines by this evening's program. Very much eager to listen to everybody.
Thank you, Padma ma'am. And now we are waiting for your papers on thin endometrium. so maybe like thinkers and researchers like you who just stimulate our thinking. You read about poor ovarian reserve, you open her papers. You read about female genital tuberculosis, you read J.B. Sharma and you read Sonia Malik. So there are so many people in India who are igniting our thought process. Thank you, Padma ma'am, for being with us today. And now, without further ado, I think we hand over the program to our coordinators. Our Purnima, is that the way?
Yes.
Yes. So I now introduce you to my two very sweet MOCs, Dr. Manisha Jain and Dr. Purnima Tiwari. Dr. Manisha is my team of perfection and symbiosis. She is also the treasurer of our society in Bhopal and the executive member of MPOX, a very hardworking gynecologist who has been at the forefront while organizing ISAR Bhopal and several other conferences. She is a keen academician and also a professor at People's Medical College and Research Center Bhopal. Welcome you, Manisha. And Purnima is also a very hardworking young dynamic gynecologist at Sage Apollo Hospital Bhopal and she has got great, UG and PG credentials, and she is the recipient of the Manish Banker Award, which will be awarded to her at ISAR Bhubaneswar. Congratulations, Purnima. We are very proud of you. And now I
Thank
hand over the sessions to my MSCs.
Thank you so much, ma'am, for your kind words. So now let's move forward for our first session. Our first session, the topic is refractory endometrium, and our chairpersons are Dr. Kersi Avari sir and Dr. B. Kalpana madam, and our speakers Dr. Reshma Pai madam. Dr. Kersi Avari sir has done MSc PhD Reproductive Endocrinology, awarded Lady Tata Junior Fellowship during the tenure of PhD program, and postdoc andrology. Sir has various publication and having teaching experience, vast teaching experience, having area of interest in assisted reproductive technology, application support and troubleshooting, cryobiology, and electron microscopy and cytology. Sir is founder director, Embryology Academy of Research and Training, consultant freelance embryologist, application support specialist ART in embryology and cryobiology, chief instructor in ART, trained doctors from all over the globe, and work in collaboration with doctors in India and abroad also. Invited as a speaker to deliver lecture in the field of embryology of national and international conferences. We welcome you, sir, today. Thank you so much for joining us today.
Pleasure having me. Yeah.
Our next
Thank you.
chairperson is, thank you, sir, Dr. B. Kalpana madam. Madam is, we congratulate madam. Madam has currently been elected as chairperson Foxy Infertility Committee. She is president Madurai chapter of TAPISAR, past founder secretary Madurai chapter of TAPISAR, peer review of Jogi, co-chairperson Infertility Committee TNFOG, vice president MOX 24, post-director for postdoctoral fellowship in endogynec, director of Guru Hospital, NABH accredited hospital, member of institutional ethics and principal investigator in clinical trial. She is active member of SR for 17 years. So many awards ma'am has received, and having vast teaching experience as well. Thank you so much for joining us today, madam. So I would like to hand over the session to our chairperson for further proceeding. Thank you. Dr. Kersi, sir?
Yeah. So good evening, all of you. At the onset, let me congratulate Dr. Monica and Dr. Randir for holding this beautiful session. And we are sure we are going to have a lovely time ahead of us. Myself, in the capacity of an embryologist, of course, won't be dealing much as the gynecological aspect is concerned, but being an embryologist, endometrium seems to be a very perfect organ which needs to be detailed debated upon onto. And it's a pleasure to be a part on the team of the Perfection Series Season 10, which is ISAR sponsored. And today's theme is refractory endometrium. So me and my co-colleague, Dr. Kalpana, will be along with you in this session. So we will be having the first speaker, Dr. Reshma Pai. So can we just have her and follow her up with the talk?
Yeah. Thank you so much. Actually, it is my privilege to be a part of this wonderful series organized by Monica and Dr. Randir. It is, we are really blessed to have Nandita ma'am, Sujata Kar, she'll be joining shortly. Sunita ma'am, Durusha ma'am, Reshma ma'am, Sanjeeva Reddy sir, Padma ma'am. Refractory endometrium is really a common topic we encounter in our routine UPD. Actually, prediction is possible with its thickness, morphology, Dopplers. But even then, very thin endometrium may be receptive. So even vascular endometrium may be non-receptive. Endometrial receptivity assay, sometimes it has got a debatable role, and counseling is really, really difficult. When we want to cancel the cycle and plan for SUT, the patient would immediately ask, what is my chance of getting normal endometrium, normal receptive endometrium in the next cycle? So really, we don't have enough evidence. Let us look into the literature evidence. And when we have great speaker, Reshma Pai madam. Madam has been introduced, but she has occupied various prestigious posts nationally and internationally. Brain with beauty. What else I can tell about Reshma ma'am? Actually, Madam has occupied, is a president of ISAR, FOGSI, IIGE, MOGS, and now into FIGO. She would reach higher heights in FIGO in another few years, hopefully. And now she's the treasurer of International Federation of Fertility Societies, and we have seen Madam's organizing skills in various conferences, recent Femtech, and also we are looking forward to AICOG in Mumbai and also ESHRE collaborated conference. Ma'am, looking forward for your excellent talk. Over to you, ma'am.
Thank you. Thank you, Dr. Karsey. Thank you so much, Kalpana, for the warm words. And I think we should straight away dive into the presentations. If you just give me a minute, I'll try and share my screen. All right, is that fine? Can we?
Yeah, it's it.
Yes, yes.
Lovely. All right. So, good evening once again. And let me begin by saying, I think not only for my talk, but for this entire session, that every complex problem has a simple solution. That very often doesn't work. We hope to, at the end of this Perfection series, find some solutions which work actually for these complex problems that we encounter, especially the problem of refractory or thin endometrium. And this really is one of the most frustrating issues when we are doing not only IVF, but even in IUI cycles, when we cannot improve the endometrial thickness. We are already feeling sort of dismayed about the outcomes of that particular cycle when embryos are good, eggs are good, but the endometrium is poor. So we all know that successful implantation requires really good embryo, appropriately timed and arranged endometrial receptivity, and an efficient crosstalk between both of them. And we have a very narrow implantation window for this. That is that period of time during which the endometrium is optimally receptive to the implanting blastocyst. And typically this happens between cycle day 20 and 24. We know that the receptivity during this window depends on many different factors. One important factor is morphological markers, of which one of them is endometrial thickness. There is also the echogenic pattern. Dr. Kalpana just mentioned that the blood flows, the volume of the endometrium. And we know that during implantation, the endometrial epithelium has mainly 4 different cell types: microvilli-rich cells, spinopod cells, vesiculated cells, and ciliated cells. And this also is fairly macroscopic. What we don't know is what happens even deeper and at a microscopic level than this. And so many different factors are working at the same time. There are biochemical, genetic, there are functional markers, and of course, the anatomical factors. The anatomical factors are the ones we are most comfortable with. If there are fibroids in the submucous area, there is adenomyosis, there is endometritis, we can deal with those things, adhesions, we can identify them, we can treat them. And most gynecologists are comfortable when they find a problem like that because they feel they can treat it. However, there are many other areas in which we don't have the knowledge, the information, and the expertise to diagnose and treat. Some things like endometrial adhesion molecules and anti-adhesion molecules, the endometrial cytokines, the growth factors, the immune markers at the level of the endometrium, endometrial glycogen, insulin-like growth factors, leukemia inhibitory factor, the various microbiota, which are becoming more and more important today from point of view of implantation and continuation of a healthy pregnancy. So you realize that there are so many things which we know so little about at this moment, and which is why there is a bottleneck at the level of implantation. So despite such a great deal of research, many good embryos fail to get implanted. And recurrent implantation failure is really a major cause of repeated IVF failure. Around 10% of women seeking IVF will experience recurrent implantation failure. And of course, there is more and more focus that the embryo is most important, the environment less so. But even then, a large number of patients with perfect embryos will not become pregnant because of endometrial factors. So all this reduced endometrial receptivity due to many different causes, including thin and refractory endometrium, are important causes of recurrent implantation failure. So what are the various factors we can look at, and what are the actual studies supporting this? When you look at frozen embryo thaw cycles, and I put this first because most of us are doing more frozen embryo transfer cycles than fresh transfer cycles. And in these recent studies of more than 10,000 hormone replacement frozen thaw embryo transfer cycles, these were based on, they were separated or demarcated based on the endometrial thickness. And it was really concluded from this large study that there was a strong correlation between endometrial thickness and implantation rates, clinical pregnancy, and live birth rates. So really, they put the cutoff at 8.7 millimeters. And when the endometrium is less than 8.7, every millimeter of endometrial thickness increased implantation rate by 32%. So that's a huge increase in pregnancy outcome by increase in endometrial thickness. So ideally, the optimal live birth is obtained when endometrium thickness ranges 8.7 to 14.5 millimeters. So too thin, too thick, not adequate, is not perfect. What we need is 8.7 to 14.5 specifically for frozen thaw cycles. What about fresh cycles? If you're doing a fresh embryo transfer, again, a large study of 10,000 plus cycles where they divided the patients as per their endometrial thickness. And it was found that the best clinical pregnancy outcomes were in thick endometrium. When the endometrium was more than 11 millimeters, that's when you got the best outcomes and the least abortion rate. So it's not just becoming pregnant, but carrying the pregnancy through to a live birth. So endometrial thickness is one of the independent variables predictive of, abortion rate, clinical pregnancy rate, and live birth rates, as shown by this big study. Not only IVF, even in IUI, as I mentioned earlier. This is one of the largest studies in IUI and looking at endometrial thickness. And here again, they divided the endometrial thickness into various groups. And the highest rate, even in IUI cycles, obviously the patient is ovulating, husband count is reasonable. The highest outcome came when the endometrium was 10.5 to 13.9 millimeters. And the odds of pregnancy really increased exponentially, 38%, 44% increase in rate if the endometrium increased beyond 10 millimeters. So it's really important to have this good, receptive, thick endometrium. However, this is the non-linear relationship. There's no direct relationship, directly that everything else being, constant, endometrium keeps on increasing and you get a higher pregnancy rate. So endometrial thickness in isolation is a poor predictor of IUI outcomes. All the other factors also have to be good, including endometrial thickness, to get the outcomes. And therefore, it cannot be a sole indicator for cycle cancellation. So what really is thin endometrium? We define it, and many of the organizations, the Canadian Society, Chinese expert consensus have said less than 7 millimeters on the day of HCG or ovulation is a thin endometrium, or the day when you're going to start progesterone. If your endometrium is less than 7, it is thin. And the prevalence is variable, maybe 2.4 to 8.5%. What are the causes behind it? Many different etiologies. It could be inflammatory causes, acute or chronic infection. Tuberculosis could be a common cause in our country. It could be iatrogenic, surgical, vigorous DNCs, myomectomies, hysteroscopic myomectomies, polypectomies, etc. Continuous use of drugs such as clomiphene. Or it could be just idiopathic from individual uterine architecture or the intrinsic properties of the endometrium that affect its growth. So typically, we see there is poor growth of glandular epithelium, high uterine blood flow impedance, decreased vascular endothelial growth factor expression, and poor vascular development. These are all characteristics of this poor, non-receptive, refractory, thin endometrium. It's easy for us to diagnose sonography, color Doppler, and we can pick up the thickness and vascularity. Of course, sometimes we have to do a hysteroscopy to pick up undiagnosed pathologies such as adhesions, infections, etc., or take a biopsy to check for endometritis, and sometimes assays such as the ERA test for receptivity assay or the BCLX6 type of assays are also done, or specific infection assays can be done for diagnostic purposes. We've already underlined the importance of not only looking at the typical thickness, but the wonderful type A pattern that we want, a triple line pattern, central hypoechoic line surrounded by two hypoechoic layers. And we know that B and C, which are isoechoic or hyperechoic endometriums, are not very favorable for pregnancy. So triple line endometrium, nice and thick, is what all of us are looking for. And studies have been done for endometrial volume. They don't seem to be a very close correlation with volume and pregnancy. So also the vascularity, all of us know that we should have good subendometrial blood flow. But again, even if you look at the vascularization flow index and vascularization index, etc., there's not been very, very clear guidelines as to direct correlation between vascularity and implantation rates, though there is definite improvement in vascularity and volume. So we want to know what is really happening at the ground level, what is there in the endometrium that is causing implantation failure. And you can actually see when you take a biopsy during the mid-luteal phase and you analyze that endometrium, the transcriptomes are analyzed with microarray. There are more than 318 upregulated genes, 320 plus downregulated genes in this thin endometrium. They have aberrantly activated immunity, natural killer cell cytotoxicity, increased number of inflammatory cytokines. All this is evident in the thin, unresponsive endometrium. And various genes related to metabolism and antioxidative stress are downregulated in this thin endometrium. So essentially, it is an aberrantly activated inflammatory environment and an aberrantly decreased response to oxidative stress that is found in these endometrium when you analyze it deeply. So having said a little bit about the diagnosis, what it is, why it happens, now, do we have any treatment strategies? And I know today we're going to have some wonderful detailed discussions on the subject. So I'll just touch upon some of the important strategies that have been looked at for treatment. So what are the therapeutic alternatives? Basically, three approaches: hormonal treatment, vascular treatment, and growth factor treatments. So starting with the hormonal, what can you do? You can basically, in a hormone replacement cycle for embryo transfer, you can do three strategies. You can either increase the estradiol administration dosage and duration. You can keep on giving estrogen longer and higher doses. You can actually change the route of administration. So from oral, you can go to vaginal route or subcutaneous. Now we have gels and sprays. So change the route of administration, or we can actually change the molecule type. And, you can use synthetic estrogens, you can use natural estrogens, you can interchange and see if there's a better response. What about other approaches? For example, we know that if a girl has been on clomiphene for a long time and her endometrium is less than 7, then you need to shift her to gonadotropin. So either add gonadotropins or replace clomiphene with gonadotropins, and you'll get a better endometrium. And this particularly is for IUI cycle. So at least the iatrogenic factors we can remove. We can even switch drugs from clomiphene. We may switch to tamoxifen. And there are certain studies which have emphasized that gonadotropins, of course, and even tamoxifen, 40 milligrams per day, will give you a better endometrial thickness than clomiphene, which has a negative impact on endometrial thickness in a large group of patients. So we can move from clomiphene sometimes to tamoxifen before we move on to gonadotropins, specifically with the purpose of improving endometrial thickness. What about simple interventions like the use of HCG? There are many, many studies which are saying that even a simple intervention like infusing HCG, 500 units, 15 minutes before embryo transfer, actually will improve the implantation rate. And this actually improves the chemokine-triggered embryo endometrial dialogue, intensifies angiogenesis and the immune response, and may improve pregnancy rates in patients who have recurrent failure. So that's an inexpensive, simple intervention that we can do, infuse small dose of HCG pre-embryo transfer. What are the other things we can do? Again, simple interventions, use of GnRH agonist. This has been tried in the luteal phase. It works in many different ways. You'll be surprised to know. The GnRH agonist may directly act on the embryo, the placenta. It may act via its receptors on the endometrial surface. And the single dose GnRH agonist in the luteal phase actually may increase pregnancy rates and even live birth rates. So simple interventions may work. Coming to the vascular approaches, are they relevant? Are they actually showing results? We all know that vasodilators have been tried for years to improve the endometrial thickness, relax the uterus, improve receptivity, but there's unfortunately not great evidence in the favor of vasodilators. Sometimes endometrial thickness may be improved, but outcomes really don't improve. Sildenafil has been tried, and implantation rate may be a little higher, but no magical outcomes seen there. Aspirin has not really shown to give beneficial effect. So we all have used aspirin, we've used sildenafil to improve blood flow, etc., but the outcomes are not that positive or encouraging. What about the use of GCSF? Again, for many, many years, we've been using GCSF in difficult cases because granulocyte colony stimulating factor, is a glycoprotein which has growth factor and cytokine factors, and it actually enhances the cyclic AMP-mediated desodalization of endometrial stromal cells in both autocrine and aparacrine functions. And it definitely has positive immune benefits. Is the recruitment of the dendritic cells, promoting Th2 cytokine secretion, and stimulation of various pro-angiogenic factors. So USA, actually, FDA has approved it for implantation failure and repeated miscarriages. And it's easily available to us. It's not very expensive. And you can actually administer GCSF in various ways. You can give it intrauterine infusion, subendometrial injection. You can even give it subcutaneously. And there is some evidence, not fabulous evidence, but some low-quality evidence that it may improve pregnancy outcomes, particularly in IVF failure patients. PRP, platelet-rich plasma, is another thing all of us have used since the last few years in order to improve endometrial thickness and implantation and pregnancy rates. Because we know that this platelet-rich plasma contains 4-fold higher platelets, greater amounts of growth factors and transforming growth factors, and actually has a very positive role in endometrial proliferation, improving implantation and pregnancy rates. So there are many, many studies, if you were to look into literature, supporting the role of PRP in poor and refractory endometrium. So also stem cells, lots and lots of studies on stem cells because they have an effect on tissue repair. They go into the injured site and they secrete chemokines, they modulate the immune system, they differentiate into other cell types, and they actually have antimicrobial activity as well. So you can either do systemic injection of stem cells, seems to be more effective than direct intrauterine injection. And many different stem cells, the menstrual-derived stem cells, bone marrow, umbilical, adipose-derived stem cells have been tried and may have a role to play in endometrial regeneration and improvement. In fact, this interesting study, fairly recent, on the use of human amniotic mesenchymal stem cells, which actually do endometrial regeneration, and using PPCNG, which is a biomaterial mixed with gelatin as a scaffold. So there are many studies which say stem cells have to be delivered on a scaffold. Could be a collagen scaffold, something to carry it to the site and then coat the endometrium or inject into the endometrium and have it starting its function. And it's found to actually increase thickness, the vascularity, reduce fibrosis, and improve implantation. So various methods have been tried. But we know that all of these things come with limitations. None of them are perfect and give a solution to very refractory endometriums. In certain cases, we may have to resort to surrogacy. Of course, if our government allows us to do surrogacy, then certain patients with an absolutely dismal endometrium may have to resort to surrogacy. Rarely, and of course, this is not commonplace, uterine transplant can be given in patients who have a completely damaged endometrium, absolutely terrible Asherman's, not improving with medical or surgical therapies. Uterine transplant may be an option. And of course, in the future, simpler, better treatments, diagnostic methods are coming in. And just to mention one or two of the latest ones, mucosal biomarkers, and that would be great if we can just check mucus in the female reproductive tract and check the cytokines, chemokines, growth factors, etc., which influence implantation. We could non-invasively analyze receptivity. And already certain targets have been identified, such as urocortin, activin A, interleukin-1 beta, TNF-alpha. All these are actually being worked upon as markers for implantation, which we can check non-invasively. And really, let me end by saying that the current tests of the window of implantation, such as endometrial thickness, all the assays that we have, receptivity assays, do not consistently improve clinical outcomes. So we really are looking at 5 possible and interrelated mechanisms which regulate the endometrial window of implantation. So the focus is on synchrony between the endometrial cells, synchrony between the endometrium and the embryo, standard progesterone signaling and the endometrial response to progesterone, silent genetic variations, and of course, the typical morphological characteristics of the endometrial glands. So the biological basis of these current clinical markers or tests of window of implantation is poor. And that's why the future studies to elucidate the mechanism shaping the window of implantation and to investigate potential markers on these mechanisms are required. And these are going to be the areas of focus in the future. So I always end by saying that the more I live, the more I learn, and the more I learn, the more I realize, the less I know. We know still very, very little in this huge field, which is yet unknown to us, the endometrium and all the mysteries that it contains. Thank you. Thank you very much.
Thank you so much, ma'am. Actually, with your almost 3 to 4 decades of clinical experience, finally you have entered, you know very less. And what shall we tell with our little experience? And it is really difficult to cover from definition to treatment modality in a very short period. You have extensively covered with recent advances also, and surrogacy. It is going to be really tough with stringent laws and uterine transplant. Maybe the future, it has got a long learning curve. Anyway, we will also learn from you a lot in the future also. Thank you so much.
Thank you. Thanks.
Thank you so much, ma'am.
That was such a beautiful talk, Rishma ma'am. You took us through all the therapies and you told us which are backed by evidence and which are not. And you also gave us the hint that surrogacy laws maybe in future might be relaxed a little bit. But I think ART is a debate in itself. Thank you so much, Rishma ma'am. Thank you.
Yes. Thank you so much, ma'am, for such an elaborative lecture on refractory endometrium. Can we move forward up for our next session?
Yes, please.
So for our second session, the topic is thin endometrium, overview and role of hysteroscopy in assessment. Speaker is Dr. Sudha Tandon, madam. And our chairpersons are Dr. Seema Pandey, madam, and Dr. Asha Jain, madam. Dr. Seema Pandey, ma'am, CV, please. Madam is currently President Azamgarh Obs and Gynae Society, 18 to 22, National Executive Committee member as part 21 to 23. She's co-author of A to Z of PCOS, Everything You Wanted to Know About PCOS. She's co-editor of ART and Fertility Enhancing Surgeries, the Synergy, Ovulation Induction Simplified, Foxy Handbook of Drugs in Infertility, Foxy Focus Preterm Labor, Executive Board Member of Commonwealth Association for Health and Disability. Ma'am is Director at Seema Hospital Private Limited and Eva Fertility Clinic and IVF Center at Trolli Azamgarh, UP. Ma'am is infertility and reproductive endocrinology, having a special interest in PCOS, adolescent health, early pregnancy failure, spreading awareness about PCOS and adolescent health among rural women, and a school going.
Fine, stop now.
Thank you so much, ma'am, and so many awards and achievements into your credit, ma'am. Thank you so much, ma'am, for joining us today. Our next chairperson is Dr. Asha Jain, madam. Madam is having a vast experience. She is running Foxy Recognized Center in Ultrasound and Colposcopy. Ma'am is Director, SMSA Hospital, Raipur, Medical Director, Cancer Prevention Relief Society, elected member, CG Medical Council, Zonal Chair, Foxy Food Drug Medical Surgical Equipment Committee, West Zone, Chairman, Mission Pink Health, IMA Raipur, Executive Member, ISCCP. She's immediate past president, Raipur Ops and Gynae Society, having done various trainings and having field of interest in saving the uterus, fetal medicine, Ops Gynae, critical care, and preventive oncology. We welcome you, madam, today. So now I would like to hand over the session to our chairpersons for further proceeding. Thank you, ma'am.
I would just like to take a half a minute, Purnima, and I want to wish my respected senior, Dr. Asha Jain, ma'am, all the best for forthcoming elections. And I would like to wish my very, very dear friend, Seema, all the best for the future elections. And
Thank
they
you
really,
so
really
much.
deserving, hardworking candidates.
Thank you so much, darling, and all the best from my side to you. And it's wonderful seeing how beautifully you've grown and doing all these programs. I'm so proud of you.
Thank you, dear. Thank you.
Thank you, Dr. Monica. Thanks a lot.
Thank you, madam.
And the same to you as well.
Hi,
Thank
Dr.
you,
Asha.
thank you, ma'am.
Hello.
Yeah.
CV, please.
Yes, so we are going to have our very own, a very good friend, senior, and an elegant lady who is a specialist of hysteroscope, Dr. Sudha Tandon from Mumbai. And I take pride and honor in introducing Dr. Sudha Tandon. She is gynec endoscopic surgeon and IVF consultant with more than 25 years of experience. Dr. Sudha is director to Dr. Sudha Tandon Fertility IVF Gynec Endoscopy and Maternity Hospital. She has many things to her credit, and I liked her quote written on her CV that is inspired by purpose and driven by passion. That's what we all are. Dr. Sudha was Joint Secretary IAG, is in fact IAG 2023-2024, MOGS and ISAR committee member. We had privilege of doing it together. Organizing chairperson of MOGS IAG Endo Art Conference and Workshop Mumbai 2018. So there was also Foxy chairperson Sexual Medicine 2017-19. Dr. Sudha has been felicitated on Teachers Day by MOGS in 2021 and AICOG Jan 2002 winner for the best presentation on fertility enhancing hysteroscopic procedure. And if one pre-IVF hysteroscopy done in expert hand, I believe that can change the whole future of implantation and this endometrium, which we are going to look on at later date. Over to you, Dr. Sudha, and welcome.
Thank you so much, Seema, and for the wonderful words. You've been very kind. And it's a real honor and pleasure to be here in this webinar. Must thank Dr. Monica, Purnima, and Dr. Randhir, and wish them all the best, Monica and Randhir, for their upcoming elections. And you also, Seema and Asha Jain, madam. And it is wonderful to have such, great names in this webinar, Dr. Durusha ma'am, Dr. Rishma Pai, Dr. Nandita, and Dr. Padma. So with those few words, I will start my presentation. Dr. Rishma has done a wonderful job, of a review of all the literature that is there for thin endometrium. Yeah, I'll just start my presentation. Yeah, can I share my screen?
Support.
Yes, ma'am. There is a share screen button at the bottom,
Yeah,
ma'am.
I will start, yeah.
Yeah.
So is it seen now?
Yes, ma'am.
Yeah, all right. So Dr. Rishma has really done justice to what I'll be talking. So I can really quickly go over to the videos. So let's quickly look into the overview, what I have. There will be an overlap because it's a very interesting topic and there is so much that one can really say. So yeah, well, we all know that in spite of having good embryos, in spite of having everything in place, still implantation is the rate limiting factor in achieving pregnancy for most couples. And at times it becomes very difficult for us to explain to our couples. It is still poorly understood and most of our patients may not accept this, that we are unable to explain to them, but that is the limiting factor. So you have, in spite of everything, you have just the implantation rates of 20 to 40%. And the markers of the window of implantation, you can do histological studies, which has been discussed, microarray studies. Possibly it's not very practical. There is feasibility and the cost factor. Sonography is most cost effective and reliable, and we do it routinely. All of us have very good sonography machines. We have invested in good sonography machines, and we are routinely doing transvaginal sonography and having making the reports. So what do we see on sonography? Morphological pattern, the blood flow to the uterus, the junctional zone, and the endometrial thickness. Let's quickly look into each one of this. How thin is actually thin? Well, there is no agreement on this point of thin endometrium and endometrial thickness, because we all have faced that endometrium may not grow beyond 5 or 6 millimeters, and we feel hopeless that this patient will not conceive. And I've had cases where with 5 millimeters, a 45-year-old woman conceives, where I've cancelled cycles in the previous time, but she comes with a pregnancy test, and from telling her that you're not going to, the chances are very minimal, and then she comes with a pregnancy test report and she carries twins to term. So that is something which cannot be explained. But by and large, it is 5 millimeters to 15 millimeters is the range. And what is the evidence that is there? That even with 3 millimeters, there has been a pregnancy, and ERA, though it's little not very popular, and lot of debatable issues with ERA, but it could give a clue in some of the cases. So does endometrial thickness, does it affect ART outcomes? Now, this is 14 studies that have been done and 4,922 cycles, where it has been shown that the endometrial thickness in patients who got pregnant was definitely higher than in the non-pregnant, the mean difference being 0.4 millimeters. Then this was another study by Cassius et al. In 2014, where 22 randomized control studies were done, and the cutoff was 7 millimeters, and you had a range of 6 to 27, and the pregnancy outcomes were analyzed. Again, here, this shows that when the endometrial thickness between less than 7 and 7, the probability of a clinical pregnancy was definitely better, or it was lower in women with less than 7 millimeters. So this was the conclusion of this study. And this is a very interesting study because it correlates the age factor also. So when the endometrial thickness was less than 7 and the mean age was higher, so the number of oocytes retrieved were also lower when compared to the endometrial thickness being 7. So age is definitely a contributing factor for getting less eggs, but whether it is a contributing factor for or it is a factor which is present simultaneously in the same patient, is probably that one may have to look into it. Thin is no good, whether it is for endometrium or for your body type, and definitely for a thin crust pizza. So what about the endometrial pattern? Is it important? So various schools of thought, yes and no. So both are there for pregnancy, successful pregnancy. This is what it says. There's no clear association between the endometrial thickness. Now, the endometrial thickness or pattern was not found suggestive of clinical outcomes of euploid embryo. Now, especially in the type 3 pattern, where the progesterone levels at the time of trigger was more than 1.5. So this was suggestive that even if the embryo was euploid, it did not support a pregnancy. The pregnancy rates were less. So this is an important factor that one may consider, or one should consider, especially when you're doing a fresh transfer, fresh or frozen. What about the frozen thaw embryo transfer cycles? Is it different? Well, almost the same. When HRT was used, the endometrial thickness, if it is more than 8, revealed higher pregnancy rates and good ongoing pregnancy rates. It improved when the endometrial thickness was 8, and this was valid for both young as well as advanced age. So there is no solid conclusion on the optimal endometrial thickness cutoff. It appears that at least 7 millimeters endometrial thickness is optimum, whether it is fresh cycles or frozen thaw cycles. So what is the reason for the low implantation rate? These are the theories: estrogen receptor abnormality, function hypothesis, oxygen tension theory, which was proposed by Casper in 2011, impaired angiogenesis and altered blood flow in 2007 by Viva. So this says that the spiral arteries with high oxygenated blood flow was found. And this was the cause, the high oxygenated blood flow was the cause of the endometrium being thin and reduced pregnancy rates. This was an altered angiogenesis, which was responsible, and the uterine and the radial artery, the RI index was increased, and this affected the glandular epithelium, and the number of blood flows are decreased in thin endometrium too. So this was the issue. This was one of the proposed issues. So what are the reasons we have? This has been discussed. Most common being the DNC, especially the post-abortion obstetric curettage, accounts for 90% of the causes. Ablation, not very common now. Aggressive myomectomy, especially if you're doing a hysteroscopic myomectomy, and especially if there are more number of submucous fibroids, the anterior wall and the posterior wall together, that can give rise to thin endometrium and intrauterine adhesions. Post-Strassman surgery. Also, one important is when you're doing the surgery for atonic PPH, where you take the stitches, the vascular stitches on the uterus, that has also been found to be the cause of thin endometrium. So especially these cases, if you are suspecting, then it is better that you do a hysteroscopy, a repeat hysteroscopy after your myomectomy. And it has been now proposed that you do your second look hysteroscopy almost 15 days after your first hysteroscopic myomectomy. So that the adhesions would be less and you can correct it. Radiotherapy, infection, chronic endometritis, a very important cause of thin endometrium. Prolonged OCP use, more than 10 years, clomiphene cycles, especially if repeated cycles are used for IUI, and idiopathic and congenital Mullerian anomalies. How do you treat it? First is, most important is that you do not create those adhesions. So avoiding adhesions, avoiding Ashermans, avoiding doing DNCs as a routine. I think that is one statement. That is one thing which needs to be continuously hammered, because even the patients want a DNC for everything, whether it is menorrhagia or amenorrhea or irregular periods, whatever may be the reason. They just want a DNC. They think that is the treatment for everything. So, it is the doctors who have to tell them that that is not the correct line of treatment. So for that, I think hysteroscopy courses, making them realize as what damage can be done will go a long way. And IIG does lots of these courses, and ISAR also does lots of courses. So I think it's important that one does these courses and, does it in a regular way. There are a lot of medical options. We'll quickly look into this. Invasive surgical options, hysteroscopy, bone marrow studies, transplantation, uterine transplantation. Medical treatment, estradiol, HCG, PRP and GCSF. I think Dr. Monica is going to speak. GnRH, agonist, acetyl salicylic acid, ASA, vitamins, nitroglycerin, vitamin E, pentoxifylline, sildenafil. Quickly, just 1 or 2 slides into this, and then we go into the videos. So this was, how does it work? So it acts on the estrogen receptors. The estrogen will act on the estrogen receptors which are present in the epithelium as well as the stroma. And whether you give it orally, transdermal or vaginal, it depends on how the patient responds. So it causes spiral artery contraction, proliferation of the endometrium, and it reduces the oxygen tension. So by giving estrogen. And if you give vaginal estrogen, it avoids the first pass effect. And maybe it is useful in some women who are refractory or to your oral estrogen. Now, you could give, this causes it's a high local and systemic estrogen concentration, and maybe it causes a better response. So what are the various studies that have been done? So in one study, it was 18 milligrams given for estrogen, and this was for 96 days, 101 patients, and you got the endometrium of 8 millimeters. I have not used for so many days. Maximum I have used is for 21 days. Then this was, the pregnancy outcomes are similar. This is what this paper says. 2001 paper, 10 refractory thin endometrium, where it was given for 4 weeks, 6 milligrams.
Can't see anything.
Some problem, Purnima?
Mom, even I can't listen in it. I think, I think there's some network problem with ma'am's side. Hello?
We will wait.
Yes, ma'am. Okay. Yes. Ma'am has joined back.
So is it fine now?
Yes, ma'am. Now we can see, ma'am. Can you make it slide share? The complete screen.
Ma'am, please put on slideshow.
Yes.
Thank you, ma'am.
Is that fine? Yeah.
Yes, ma'am, all fine.
So this is how does the HCG work? Either it will improve your VEGF expression, tissue remodeling, or plays role in receptivity. Okay, so you give, how do you give HCG? You give right from, and start the estrogen from day 2, and then you add HCG in 150 units subcutaneously from day 8, whether it is for fresh or for frozen embryos. And this was tried in 17 infertile patients, and there was an improvement in the endometrial thickness and also the pregnancy rate. This was one study where you give 750 units every 3 days. This also revealed, this study was prematurely discontinued because half of them were given HCG and half was not given. So probably that is the reason. Now, local GCSF, Dr. Monica is going to cover, so I'm not going to cover that. And sildenafil is also that she's going to cover. So I will, PRP is also she's going to cover. So I'm going to skip that because that is her talk. ASA, yes, it may work in some. You give about 80 to 100 milligrams.
Madam, you can speak about PRP. PRP is not in my talk, ma'am.
It's not in a talk? Okay.
No,
I
ma'am,
thought
you can speak about PRP. We will all be benefited. Thank you, ma'am.
Right. Yeah, so this is it's really widely used in orthopedics, ophthalmology, dermat, and wound healing. And how does it work? It can improve the fibroblast growth factor, which helps in tissue repair, cell growth, collagen production, hyaluronic acid. It also improves the epithelial growth factor and does promotion of epithelial cell growth, angiogenesis, and promotion of wound healing. It also improves the VEGF, which is the vascular endothelial growth factor, and in the TGF-beta, which is the transforming growth factor. So this is a lot of growth factors which improves the when you use platelet plasma. And it's not really very difficult to prepare. You can prepare it in your own laboratory, but it is always better, you give it hysteroscopically in the subendometrium and not just into the uterine cavity. But that is also one way that you can just do it in the uterine cavity. But better would be that you inject it, with the ovum pickup needle into the subendometrial area, anterior, posterior, and the 2 lateral walls. So this is one good way that you can try for patients of thin endometrium. So there are 2 ways that you can really do it, and but it needs to be validated. Somehow it seems to be effective, but it needs to be validated. Now, this was about ASA. Again, it reduces a subendometrial contractility. It is a very good anti-inflammatory agent by inhibiting cyclooxygenase and prostaglandin synthesis, improves the uterine blood flow, and you give it orally. A very good drug which can be tolerated, almost doesn't cause any side effects. So this is the various studies. But it says that the receptivity is improved because it is anti-inflammatory as compared to just the thickness. So that is how it may help. Then the other, vitamin E, is an antioxidant vasodilator. It can be used along with pentoxifylline and even decrease the radiation-related effects. That's about vitamin E. Pentoxifylline causes vasodilatation, decreases blood viscosity, inflammatory response, and decreasing fibroblast proliferation. So this is sildenafil. I think Dr. Monica is going to speak, so I will skip this. Yeah. Now we'll come to hysteroscopy. So one thing, whether we do pre-IVF hysteroscopy or no, lots and lots of papers. And the interesting part which I find is that even if the sonography, now with 3D sonography, it can almost, you may not do hysteroscopy in the first cycle, but I feel that if there is any past history of tubal problem or if there's minimal hydrosalpinx, or there are some period-related problems, or some history of infection in the past, probably these are the cases which you would, at least I would like to do before the first embryo transfer, and not stick to that, you do not do it in your first cycle. That is my own personal opinion. Because even if HSG or sonography is normal, quite often, almost 40 to 50% of the times, there are issues. It can be a chronic endometritis, some small adhesions, and and if you do hysteroscopy, just that procedure can improve the pregnancy rate. So this is what about whether you do hysteroscopy or not before your first IVF. There's a lot of debate going on. Some are for it, some are not for it. I would say that you have to, you have to choose your patient properly and not just generalize whether you should do or not do. So it can act as an endometrial scratching, and that's how it may help. And as I said, that 50% of the pathologies were not detected prior. So, and when we talk of hysteroscopic adhesolysis, it is safe, effective procedure to restore the normal menstrual pattern and fertility. So now this was about one study where 2003, 2018, and 638 patients, but Asherman's hysteroscopy was done, and adhesolysis was successful in 95% of the patient. Recurrence rate is 27.3. How many times do you do hysteroscopy? At times you have to do even 3 to 4 times, but there is a limit to how many times you can do. And sometimes have hopeless cases. So I will show you few cases which were pretty good, which improved after hysteroscopy, but some are very hopeless cases. I think maximum of 3 attempts you do. And if there are no successful outcomes, you call it a day, and then you offer them surrogacy. So this is a little bit of literature. And just this point, comprehensive sutures for PPH could be a cause of Asherman's. Mycobacteria, important factor for chronic endometritis. So this is non-tubercular endometritis that one has to look at, and not always tuberculous endometritis. So this is the way you, you score your adhesions, hysteroscopic adhesions, whether they are present at the isthmus, tubal ostia, whether they are filmy or dense, and tubal cavity, menstrual pattern, reproductive outcomes. So if it is mild to moderate, good success rate with hysteroscopic adhesolysis, severe cases, not very good success. So pregnancy rates before surgery, after hysteroscopic treatment, definitely it improves. And women with 2 or more previous successful pregnancies, live birth rate improved from 18% to 68%. Pregnancy rate after treatment in women with infertility improved. And also for women with recurrent implantation failure or previous pregnancy wastage. Of course, one must remember to use ancillary treatment along with your hysteroscopic adhesolysis, like you do a non-copper IUD, which now you don't have it over here. You don't have the Lippes loop available, but pediatric Foley's catheter, number 8 or 10, and one must learn how to put it inside. And, you can leave it for 3 to 10 days, and it really it really improves the recurrence of intrauterine adhesions. And second look hysteroscopy. There are a lot of hysteroscopic surgeons globally who talk of doing hysteroscopy after your adhesolysis within 15 days of your primary surgery. And using of hyaluronic acid as an adhesion barrier is also useful, not very freely available in our country. Good use of hormonal treatment, high dose of estrogen which can be given, and progesterone. And you see for the how much is improvement in the menstrual flow. And also you can do sonography in these cycles and see whether there is improvement in the endometrial lining. Stem cell is a very exciting and new treatment option that is available. And since I do not have personal experience with that, I would not really like to speak much about it, but I think it's very promising, and one should offer it to the patients. This is again which talks about chronic endometritis, where you give them medical line of treatment, it definitely improves. Simple, give them doxycycline, which is a 100 milligram tablet twice a day for 15 days, and it definitely improves the pregnancy rate. There are other drugs also like clindamycin, and you can take a biopsy and see for what is which antibiotic it can be, it is effective. So, but this is one chronic endometritis one should remember, and you can, for thin endometrium and repeated unexplained implantation failures. This also, it says the same thing. The hysteroscopy, there is improvement, and hysteroscopy is very good in diagnosing chronic endometritis, and very reliable, and with patients with poor implantation and recurrent implantation failures, and for diagnosing chronic endometritis. So now this, we will just look into the video. Now this is how the normal endometrium, you walk into the internal os, into the endometrial cavity, and this is how the normal endometrium looks. Preferably do it in the post-menstrual period. Now this is where we are doing the fundal and the lateral metroplasty, where in the same vision, you will not be able to see, you should be able to see both the ostia, but if you can't see, then probably these adhesions need to be cut, and scissors, hysteroscopic scissors are 5 French scissors, and you make small nicks. It is not a difficult surgery, but it's important that, the scissors have a static arm, and one of its blade is moving. So the one which cannot be moved is there. It goes into the endometrium, and then you start cutting from there. This is septum, so I'll not show this. I'll go to the next. Now this is chronic endometritis. Now this patient, we started the stimulation, and we were not planning to do a hysteroscopy, and what we found while doing the stimulation, look at these small blebs which are seen, and few of the adhesions. So we did the stimulation, we froze all our embryos, then did the hysteroscopy in the subsequent cycles, did some adhesolysis at the fundus with those adhesions are seen, and took a biopsy of those micropolyps, and the histopathology came as so you can cut, you can see, you can cut around the polyps, and then put in your 5 French hysteroscopic grasper and take out this, otherwise you will just lose it while doing hysteroscopy, right? The grasper, grasp it, and the entire assembly comes out. So your tissue also comes out with it. So this is one of the patients of hysteroscopic adhesolysis, as well as we did a biopsy of the polyp, and it came as chronic endometritis. Now this, at times, the internal os is so very tight, and the previous surgery of chronic endometritis was done by Dr. Amrita. The previous to that, which I did, now this Dr. Aditi was doing, and look at the internal os. Impossible to navigate the internal os, and sometimes you have to break the adhesions. This endometrium was just 2 millimeters, so you have to break the adhesions with your scissors and navigate your way into the endometrial cavity. And at times you cannot see the tubal ostia also, and we are trying to create the endometrial cavity you see in the video, but it was quite a hopeless case. And we have called her for a second look hysteroscopy. Let's see how it is. So this is the first. So here we are trying to navigate, with the scissors. And sometimes we would not know as to where is the endometrial cavity, whether it's on the right side or the left side. And you wait for the saline distension to occur, and then we have entered the endometrial cavity. You can also use a grasper to navigate into your endometrial cavity, especially in postmenopausal women where the internal os is very thin. And your position of your hysteroscope is very important, and very important that we cut in the center laterally. We try to get a triangular cavity, and hope that we get some pink areas after that. You see that the pink areas which suggest that we are into the endometrium, but it was a very bad case, endometrium of just 2 millimeters. And we took quite some time for it because it was very bad, severe Asherman's. So this is how it is at the end of the procedure. And we may have to do one more. This was just about 15 days back. And we are waiting for her to come back and see whether she gets some amount of period. She was amenorrheic for almost 4 or 5 years. So this was a very bad case of chronic of bad severe Asherman's. Now this is again another case of hysteroscopic adhesiolysis, where negotiating the internal loss by the vaginoscopic method is not very difficult. Now, interestingly, this patient was for, laparoscopic myomectomy. And I just did the hysteroscopy to know whether there are any fibroids which are projecting into the cavity. Unfortunately, she did not agree for a transvaginal sonography. She was very adamant that please go ahead because I've done my transabdominal sonography and it was I wish I was more perseverant with her and insisted on a transvaginal sonography. But anyway, so my point is that you know, when you're doing a laparoscopic myomectomy, you should be ready. Do your hysteroscopy before you do the lap myomectomy because you don't know there could be a fibroid and you're treating her for infertility or for IVF before implantation. You're doing the IVF for improving her pregnancy rate. But if she has a submucous fibroid, that also needs to be corrected. So this was a surprise on the operation table. She had both adhesions, intrauterine adhesions, because there was some myomectomy which was done in the past, about 10 years back. So there were adhesions, intrauterine adhesions, and a fibroid. So we had to spend quite some time taking care of the adhesions. So this is only the adhesions I'll be showing. Now look at the adhesions in the fundus. And the bulge that you see anteriorly is the bulge of the submucous fibroid. So these are adhesions at the fundus and laterally. So I cut those adhesions. You can see one of the ostia and the other ostia also. And yeah, so yeah, so you with your hysteroscopic scissors. Now, when you're using the hysteroscopic scissors, the area, that nipple that is there where you insert your hysteroscopic scissors, sometimes if it is not, if it leaks, then you will not get a good distension and you will not be able to do. So I'm cutting these adhesions and I also cut around the fibroid so that the fibroid bulge and that fibroid I could not remove by the scissor or by the grasper because it was quite a huge one. And I had to do resection of the fibroid. And so this I did, I'm just showing you the hysteroscopic. So by and large, scissors is very good for cutting the intrauterine adhesions. Yeah, but see that you have good distension. You start from the lower end, just above the internal os, and you keep cutting laterally. On one side, you go up to the ostia, just little short of the ostia, and that really does the job. So this is the bulge of the fibroid, which is there anteriorly. But she also had adhesions before that, below that. So, this video, I'm just showing you the adhesiolysis because that's the topic. So stem cell uterine transplant is the other option. And I will not go into the detail of that because I've taken that 30 minutes which was given to me. And yes, that's it. Thank you very much. Uterine transplant, a very exciting option. But honestly, I have spoken to a few patients. Maybe I could not convince them, but they said, no, you just do a hysteroscopy or we go for surrogacy. They're not very excited for a uterine transplant, but I think it's one option that we need to consider and we need to tell. And I'm very happy Dr. Shailesh Puntambekar has put India on the map of uterine transplant with his successful with the success of uterine transplant. So definitely you cannot not do hysteroscopic evaluation. It is a priority. What all can you do? I think as time goes, you keep learning more and you increase your skills, starting from diagnostic to operative surgeries, and you should have good equipment, and then keep on doing. If it's a very bad case, then I think it's better that you call a senior or somebody who's good at it. But please do a very good justice in the first instance itself. Thank you for your patient hearing, and thank you, Dr. Monica, and wish you all the very best. All of you who are contesting for the elections, we have voted for you. Sorry. I'll stop share.
So after the chairpersons, I would like to speak about Madam. Chairperson.
Thanks a lot. Thanks a lot, Dr. Sudha. That was so good. I'm not an IVF person. So for me, it was very eye-opening. Yes, we do hysteroscopy, but your insistence that there is something that can also be done for a thin endometrium, that is something that we sort of give up. And even when they go to IVF centers, most of the time, they don't really conceive. So most of them. So thanks, Dr. Monica, for keeping this topic, because that is really the limiting factor whenever we are treating infertility, whether it's IVF or normal infertility. So, and Sudha ma'am, you really did great justice to that. Congratulations for that.
Thank you so
and
much.
Thanks for the wishes as well.
Thank you. And you made a very valid point, and that, hysteroscopy should become a routine now, I feel. And, unfortunately, I don't know, in most of the where the postgraduates are getting trained, it is by and large, I still feel it is not done in most of the hospitals, because it takes one to be really magnanimous to accept that hysteroscopy and laparoscopy is the way forward, and we cannot deprive our postgraduates from this.
Agreed.
Yes. Yeah.
The patient,
Thank you.
you need to do it. But one thing is, this endometritis thing. This endometritis that is coming up, it need not be after DNC. It could also be after the number of medical abortion thing that is happening. Because there is some retained product and the patient, just goes on bleeding for a month or two. She's having spotting. And that is leading to endometritis. And these days, the girls who come to you, means they've had an MTP long back, which they don't even remember. Tab nahi chahiye tha, ab chahiye hai. So, that also should be part of the DD is what I feel. So thank you.
Absolutely.
Thanks a lot, ma'am.
Thank you.
So, Sudha ma'am, I must put in a word that I was sitting with Sudha ma'am in Nagpur in hysteroscopy carnival of Sushma Deshmukh. We were chairing a session of great stalwarts like Osama Shauki and Milind Telang, and we were enjoying the surgery. And I was having a bad episode of allergic rhinitis after that, train from Bhopal to Nagpur. So I just, madam, aapke saath ek karna hai. I have to do one perfection with you, and it has to have hysteroscopy. It has to have you. It will have Aditi and Amrita also. And we formed it there on the stage.
Yes.
And today, when we were trying to air this webinar, another thing, came to me. I was just talking to somebody and it just struck me. I was talking to Tanya Bakshi Seema yesterday. I told you I was talking to Tanya. I said, Tanya, what is your favorite topic? She said, I want to talk about male infertility. I said, Purnima, let's do male infertility. February is male infertility. I was talking to Jyoti Banglawala, let's do medical legal. So we form 1 month in advance. We prepare 1 month in advance. That is why you get this quality of webinar, you get this quality of speakers. I told my girls we'll do less, but it has to be good. It has to be the best in India. It has to be the best topics in India, the best chairs, the best comments, and we'll continue. Irrespective of the result of the election, it is going to continue. So, madam, thank you so much, Sudha ma'am, for motivating.
Thank you.
I'll tell you another little story. I was on a campaign for Sunita Tendulkar madam, and we were in a taxi from Indore to Ujjain or something, and I was in the car with Farendra Bharadwaj, who is a very good hysteroscopic surgeon. And he said, Monica, madam, tell me what is more difficult, laparoscopy or hysteroscopy? I go, come on, Fareen, laparoscopy is more difficult. What you're saying? No, you're wrong. It is hysteroscopic surgery which is more delicate, more difficult, and you have to have a bigger learning curve for that. So that set me, thinking that, now like all my procedures are vaginoscopic. I try to do a little more every day, and now I'm making a state of the art theater for myself. Last time I just called a hysteroscopic Hystromat, the new version in which the pressure adjusts according to the volume and the pressure in the uterine cavity. All these gadgets make life so much simpler. And uterus, you have to see it to believe it, what all pathologies can be there inside the uterus. Madam, you have done a tremendously brilliant job, Sudha ma'am. And I'm so thankful to Tandon family for being the captain of the ship today.
Thank
So
you,
over to
Monica, for your kind words. Yeah, I
Thank
think you
you.
rightly said that I have really been impressed by the perseverance of your team about the webinars. I think it says a lot about the captain. That is you.
No, these girls are sick of me actually. But now I'm giving them a 2 weeks holiday because we are all going to Isar Bhubaneswar and we are practicing a cultural event. We are dancing and all that, So now
Right.
2 weeks holiday for us, and then we are back to work. Thank you so much, Sudha
So
ma'am.
just think hysteroscopy is what
Yes,
I
ma'am.
would say as the last word. Think hysteroscopy, do hysteroscopy, enjoy hysteroscopy. Thank you very much.
Perfect, madam. Perfect words for all the audience.
Thank you.
All the audience. Perfect words, madam. Thank you, ma'am.
Thank you so much, ma'am, for such a wonderful lecture. Now, let's move forward for our next session. So our third session is on recurrent implantation failure, an embryologist perspective. And our speaker is Dr. Ashwini Kale, madam. Our chairpersons are Dr. Nirmal Bhasin, madam, and Dr. Shabana Sultan, madam. CV, please. Dr. Nirmal Bhasin, madam, is director and clinical embryologist and founder of Jani Fertility Center and MD from Minsk State Medical Institute, Belarus. Madam is member of ISAR, IFS, AIS, IMH Chandigarh, COGS Chandigarh. She is currently holding position of chairperson ISAR Chandigarh chapter, chairperson Mission Pink Health IMA, has an experience of 20 plus years in infertility. She has presented various papers in national and international conferences and has published various papers in journals also. And she is pioneer in surrogacy program in Chandigarh, Tri-City and Punjab region. We are honored to have you, madam, today with us. Welcome, madam. Thank you so much.
Thank you so much. I'm still driving, so.
Yeah, ma'am. It's okay, ma'am. Thank you for joining us, madam. Our next chairperson is Dr. Shabana Sultan, madam. Madam is professor in Department of Ops and Gynae, GMC Bhopal. She has presented various papers in national conferences. She is member of esteemed team of People's Bundle along with Sevagram. She's past Joint Secretary Bhopal Ops Gynae Society, past Treasurer Bhopal Ops Gynae Society, present Secretary Bhopal Ops Gynae Society, executive member of
Thank you.
Thank you so much, ma'am, for joining us today. So now I would like to hand over the session to our chairpersons.
Yeah. So thank you so much for involving me in this webinar, Dr. Monica, madam. And I'm delighted to invite Dr. Ashwini Kale, madam, for her talk on recurrent implantation failure embryologist perspective. She is a chief embryologist of Asha Kiran Hospital IVF Center, Pune and Hyderabad. She was Secretary Pune OB-GYN Society 2020-21. Treasurer Maharashtra Chapter SR in 2018-20. She was elected MCM Embryology SR. Chairperson MOGS 5TP Committee 2021-23. Zonal Coordinator MOGS 2018-20. And she is a peer reviewer of JOGI, that is Journal of Foxy, since 2016 till date. And she was awarded with so many awards. And one of them is Shanti Yadav Award. So welcome, Dr. Ashwini Kale, madam, for your talk on recurrent implantation failure. The mic is yours.
Thank you so much, madam. Thank you so much for the kind introduction. And thank you, Monica Madam, for having me here for this perfection series. And I must congratulate you for having them for such a long time consistently. I hope, is my screen visible?
Yes, yes. And Ashwini, I must thank you. Ashwini is like my sister. We have worked together for Sunita Madam. Sunita Madam is mentor for both of us. And Sunita Madam is the person because of which, on the pillar on which Perfection series is built. I was very depressed. I didn't know what to do, and my academic program was not working out. So I said, Madam, after Isar Bhopal, I wanted to continue something online. And she was the one who gave me the green flag. Ashwini was the one who guided me with the initial programs. And Ashwini and Ashish are like my family. She is a very good friend of Randhir also. And Ashwini, thank you for everything and welcome to Perfection.
Thank you, Madam. So, beginning today with recurrent implantation failure, as we all know that it is as distressing for the clinician as for the patient. And despite the immense studies that have been made in this field, many patients still face this dilemma. And recurrent implantation failure may be defined as the repeated transfer of morphologically good embryos to a normal uterus without achieving successful implantation and a clinical pregnancy. Traditionally, failure to conceive or to achieve a pregnancy even after 2 to 6 IVF cycles, in which more than 10 high quality, high grade or top quality embryos were transferred to the uterus, was defined as RIF. ESHRE defines it as more than 3 embryo transfers with high quality embryos or transfer of no less than 10 embryos in multiple transfers. The exact number is to be defined by each center. It can also be defined as absence of pregnancy after consecutive cycles of IVF or ICSI after fresh or frozen transfers, where the cumulative number of transferred embryos was more than 4 for cleavage stage embryos and more than 2 for blastocyst, and all the embryos were of good quality and at appropriate developmental stage. Or the failure to achieve a clinical pregnancy after transfer of at least 4 good quality embryos in a minimum of 3 fresh or frozen cycle in a woman who's under the age of 40 years. The process of embryo implantation, as we all know, depends on the synchronization of multiple factors, starting from karyotype of the parents, the oocyte and the sperm quality, quality of the embryo, chromosomal abnormalities, optimal culture conditions, receptivity of the endometrium, maternal immune system, and finally, embryo loading and the transfer technique. Coming to non-invasive embryo assessment, which can be done either by morphology, culture-bound dysmorphisms, stage appropriateness, morphokinetics, and metabolomics. As we all know that chromosomal abnormalities, there is an increased incidence of chromosomal abnormalities such as either translocation, mosaicism, inversion, or deletion that has been demonstrated in women with higher order RIF. In support of these findings, Stern et al. Observed an overall chromosomal abnormality rate of 2.5% in patients with RIF. And most of these abnormalities were chromosomal translocations, either reciprocal or Robertsonian. Balanced parental translocations may be implicated in the pathogenesis of implantation failure in IVF, and that genetic evaluation should be considered as part of the investigation of these couples. ESHRE defines good practice recommendation. PGT is defined as a test which is performed to analyze the DNA from oocytes or embryos for HLA typing or for determining the genetic abnormality, which includes PGT-A for aneuploidy, M for monogenic or single gene defects, and you could either do an PGT for structural rearrangements. It started in the 90s with PCR FISH coming to NGS, and indications like increasing elective single embryo transfer and reduced time to pregnancy have been added more recently to this list. Cited indications for PGT-A, as we all know, includes advanced maternal age, recurrent implantation failure, severe male factor, and couples with normal karyotypes who have experienced recurrent miscarriage. NGS, as we all know, the purpose of this huge study which was done was to explore the value of NGS for the clinical outcomes for RIF with advanced age. The component of aneuploid embryos was significantly higher in advanced age group than in younger age group, to the tune of almost 68%. This result suggests that the embryo-related factor plays a crucial role in RIF. NGS techniques are the latest and the most popular technique which are utilized in PGTA labs currently, and they have been routinely adopted for testing embryos by massively parallel genome sequencing worldwide. It allows for identifying and screening these embryos with either euploidy, aneuploidy, or chromosomal mosaicism. Coming to oocyte factors, we all know that polar body biopsy can be done, which is an indirect target for CGH NGS. The telomere length of the polar body is very important, which shortens with every cleavage. So older the oocyte, shorter the telomere, and it is a negative predictor for pregnancy. There are other factors in the cumulus cells like gene expression, strand breaks, apoptosis. These strand breaks appear first in the outer cells and then they reach the oocyte. Coming to morphology, which depends on the kind of stimulation or the drugs that are used or the kind of protocol that is used, the number of oocytes that are retrieved, and associated factors like endometriosis. Of all these factors, the two most important are giant oocytes, which are frequently associated with 69 chromosomes, and cluster of SCRs in the central oocyte. Here you can see a clear picture of an enlarged polar body. And here you can also see abnormalities of the perivitelline space, as there is no perivitelline space in the second picture, a large perivitelline space, or even a normal perivitelline space with the presence of fragments in it. This is how giant oocytes look like. They basically represent failed cytokinesis. They have 69 chromosomes in it, though the incidence is very less, where the size is more than 200 microns, including the zona. Now coming to the cluster of SCRs, which is nothing but smooth endoplasmic reticulum clusters, though less than 2% are affected, the normal fertilization can happen if you avoid this rupture. Though not all SCRs are seen, the blastocyst formation rate is very low to the tune of 18%. Almost 58% result in biochemical pregnancy, and there's only 13% implantation rate. Coming to sperm factors, there's a higher incidence of sperm chromosomal abnormalities in patients with normal karyotype, and RIF has also been reported. The pregnancy rate and implantation rates are significantly lower in patients with teratozoospermia. The centrosome anomalies results in chaotic mosaics, which were most likely of paternal origin, and increased DFI plays a key role in pregnancy loss, but not in RIF. This is a very good study which came in May 2021, where they actually showed that elevated DFI does not predict RIF or the recurrent implantation failure. They determined this DFI by sperm chromatin structure assay, and they found that neither DFI, as assessed by this study, was predictive of RIF or pregnancy rate. This finding suggests that sperm DNA fragmentation does not predict recurrent implantation failure. Now coming to embryo, when you have fragmented embryos, definitely the implantation is not going to happen. Then you have embryos with unequal cleavage or with a degenerated blastomere, where there's failure of the zona to rupture after blastocyst expansion, which results in impaired hatching. That could also contribute to RIF. Prolonged exposure of oocyte or embryos to artificial culture conditions may also adversely affect the embryo's ability to undergo normal hatching and could impair successful implantation. Now coming to the stage appropriateness. Here, the center picture shows how an embryo should ideally look like on day 3. And on the right side, you can see a fast-growing embryo, which is actually compacting on day 3. And the below picture shows a day 4 morula. And on the right side, you can see that actually it has turned out into a blastocyst. Whereas on the left side are those embryos which are slow on day 3 and day 4. So the chromosomal abnormalities in these human embryos, they actually showed that an accelerated growth is much better than the delayed growth, because it had normal, there was a higher pregnancy loss in those patients which had delayed embryo growth. This means that when the embryo was of a lesser cleavage stage on either day 3 or day 4, they had higher pregnancy loss, and the live birth was only 12%, which was as compared to the accelerated growth, which was almost 50%. So an accelerated growth is much better than having a delayed growth. Coming to the time-lapse technology, which is nothing but deselecting the embryo, these are the ones who do not correct themselves at the end of day 2. This could either be due to incomplete cleavage, which is more so seen in ICSI than in IVF. It could be a problem of sperm centromere, as it's a part of the first meiotic spindle. These embryos, when analyzed with FISH, were found to be aneuploid. Coming to irregular cleavages, either it could be a rapid cleavage, that is, which is a dynamic event where the direct cleavage from 2 to 3 cell happens in almost less than 5 hours, or trichotomous mitosis, which is an aberrant cleavage from single cell directly to 3 daughter cells, or it could be cell fusion or reverse cleavage. Reverse cleavage is nothing but there's a sudden reduction in the number of cells during the development, either due to merging or fusion of these cells, or embryo rolling or planar arrangement of these cells, the result of parallel oriented cleavage axis rather than being perpendicular. Coming to culture conditions, suboptimal components of a culture system, it could lead to embryo development. This could either be in your cold chain maintenance, storage, osmolality, density, pH, or even the sperm bioassay. The morphology may not change, but morphokinetics definitely can. In some instances of RIF, individualized specific culture conditions may be required for optimal embryo development. Various co-culture systems have been developed as a means of improving embryo culture conditions. The main aim is basically to increase the metabolic chances of the human embryo to achieve the blastocyst stage, because this leads to a higher implantation and finally a higher pregnancy rate. The suggested favorable effects of co-culture include secretion of embryotrophic factors such as nutrients and substrate growth factors, and the removal of free radicals and potentially harmful substances. Culture-bound conditions or dysmorphism, as you can see, a typical cytoplasmic pitting has a negative influence on implantation outcome. This pitting is different from cytoplasmic granulations. It typically appears on day 3. Vanishing implantations are seen in almost 33% of the patients, and pitting was found to be reduced in single culture as compared to group culture, probably due to EDTA. Ammonium concentration causes pitting. It may be due to not changing the media for a long time. Coming to culture media, there is a lot of study going on metabolomics, which is nothing but depletion of glucose and pyruvate and all these metabolites that are required for the growth of the embryo, mitochondrial DNA, and non-coding RNAs. Adding GCSF to the media may improve implantation in RIF. We did a small study at our center way back in 2018 in 52 patients who had previous 2 failed IVFs, where we had transferred 2 blastocysts. The implantation rate almost increased to 70% with a live birth rate of 58% in these patients. Many studies have confirmed that it causes no epigenetic change in these embryos, though it definitely adds a cost to the cycle because of adding GCSF to the media. Now coming to endometrium, there is definitely a window of implantation where there is a crosstalk with the embryo, which may or may not lead to successful apposition, attachment, penetration, and finally implantation, and possibly development and growth of a viable conceptus. The stage appropriate endometrium is very important. A total blockade or disarrangement of this sophisticated cascade of molecular signaling is needed in both the embryo and the endometrium for successful implantation and pregnancy. This immunological relationship between the mother and conceptus is still a mystery. A novel platform for discovery of differentially expressed mRNAs. This is a study which identifies these mRNAs from patients with repeated implantation failures. And they have found that 3 mRNAs were capable of predicting these patients with RIF and with an accuracy of almost more than 90%. This is definitely going to help increase the success rate of implantation. Coming to lab conditions, there are multiple lab conditions which could lead to RIF. Doing a regular QA/QC definitely helps. The air quality, presence of VOCs, checking the incubators, their CO2 temperatures, looking for the tubings, and maintaining cryotanks. This is an overall overview of all the key factors that finally help or are a part of this embryo development. Coming from QA/QC of the lab to the tissue culture, oxygen concentration, the static culture, all the albumin, the number and the type of incubators that have been used, even the oil which is used for overlay plays an important role, right to air quality, pipetting, light, each and everything plays an important role. Coming to the day of transfer. Embryo transfer at the blastocyst has been proposed as a strategy to improve the implantation rate and pregnancy in these patients. Better embryo selection for transfer, fewer embryos, and improved endometrial receptivity are obvious advantages of this approach. Live birth rate and implantation rate per cycle were higher after blastocyst transfer. Mixed double embryo transfer is a promising approach for these patients who have got repeated implantation failures. The study was done in 2017, where they found that in total women of 104 patients who had RIF, who underwent frozen mixed double embryo transfer is nothing but simultaneously transferring the embryos on day 3 and day 5. And the implantation and clinical pregnancy rates were significantly higher in patients who underwent this mixed double embryo transfer than in those who underwent a blastocyst transfer. So the pregnancy rate was almost 60% as compared to 40%. So in this way, you could give that patient an additional chance or a benefit of being pregnant. Embryo loading and transfer technique. This is again a very, very important step in the embryo transfer. It is a very skillful, time-bound, and a precise job. It shouldn't expose the embryos too long, or there should not be too much of handling. Loading too much of media or loading too much of air or aspirating the oil accidentally. These are few minor things which may lead to the implantation failures. The ET technique is also very important. It can influence the success or failure of embryo implantation. uterine contractions, blood or mucus at the catheter tip, lot of endometrial trauma, difficult negotiation, using a lot of instruments like dilators, guide, expulsion of the embryos, again reloading them and doing an ET. These can all be associated with unsuccessful ETs. So what is the prognosis for a live birth after unexplained recurrent implantation failure following IVF ICSI? This study reports a favorable overall prognosis for achieving a live birth in women who has previously experienced RIF, especially who still continue to have IVF ICSI treatments. However, since 51% did not achieve a live birth during the follow-up period, there is a need to distinguish those most likely to benefit with further treatment. So you have to know where to stop. In this clinical study, no clinical factors were found to be predictive of those achieving a subsequent live birth. To conclude, I would say that this is seen as a clinical experience and not a specific diagnosis as such. Further work is definitely required to develop and validate a diagnostic algorithm to identify those women who can expect a good outcome if they actually continue taking treatment after RIF, and those who should consider other options. Chromosomal abnormalities, sperm DNA damage, zona hardening, inadequate culture conditions, suboptimal embryo development all play a significant role in the etiology of RIF. Evidence suggests that pre-implantation genetic screening does not increase implantation or live birth rates, but CGH array and analysis of single nucleotide polymorphisms could enable a more comprehensive screening of chromosomes. Assisted hatching may help to overcome zona hardening in selected cases. Novel embryo assessment and selection procedures such as time-lapse and metabolomics may help in better evaluation of the embryo quality and viability and helps in selecting embryos with the highest implantation potential. Although embryo morphology is not an optimal approach to identify the euploid embryos, you can just deselect those oocytes and embryos. Accelerated embryo development definitely has a better prognosis, delayed ones do not. The safety and efficacy of emerging treatment modalities should be evaluated in prospective RCTs before being applied in routine clinical practice. I thank you all for giving me this wonderful opportunity to speak in Perfection series. And before I say goodbye, I wish Monica Madam and Randhir Sir all the very best for the upcoming elections. Thank you so much, Madam.
Ashwini, thank you. Sunita Madam has joined. Please stay there.
Thank you,
Yeah.
thank you.
We will now
Good evening,
wait.
Madam.
We will wait for address of Dr. Sunita Tendulkar, Vice President ISAR and President-elect 2025 Federation of Obstetrical and Gynecological Societies of India. Madam, welcome.
Can we have no slide of mine and we all see each other?
Yes,
Hi,
ma'am.
hi, Seema. That's
Hi.
fun. So cut off that because I
You're
want to
looking
meet
so
my friends.
beautiful.
सुबह
Yes,
से
ma'am.
काम कर रहे हैं सुबह
Yes,
Yeah,
से
ma'am.
this
evening,
red
madam.
is really
You're looking very
suiting you. You're
pretty.
glowing with work.
I do stem cells यार, let me be honest.
हम लोग आ रहे हैं.
मैंने अब भी post Foxy election second 2 sittings हो गए मेरे stem cells के. That may be the reason, but it's so lovely to see Randhir and Monica. They are such a amazing,
Thank
very
you, ma'am.
hardworking
Thank you,
and
ma'am.
sincere couple. The way they have taken ISAR Bhopal, they brought all of us still more closer. We are closer, and they brought us all closer. And I don't wanted my slide because I can see so many of my bachas over here. I see Sheetal, I see Ekika, I see Aditi, I see Seema, and so many. I can't take the name of each and every one, but I see all of you. And Purnima, you are doing a huge job. It's always lovely to meet you. Manisha, Madam, Anchal, Monica. Monica, hi. Kaisi ho? And Amruta also is here, 2 sisters, Tandans. It's so wonderful to see you all. And I know that this Perfection series has no connect with the elections because we started it way back now, more than I think nearly 2 years this series, and every time Monica comes out with such a fantastic. I'm so sorry I could not participate today because I had 2 parallel commitments given and I had my talk somewhere. So I just could not come, and
No,
I'm
madam,
so
it was
thankful
my
that
fault. It
Ashwini.
was my fault, madam. I could not personally send the link. I gave the job to Purnima, Manisha, and madam did not read the message. It is totally
That's
my
okay.
fault.
I just went to your.
I apologize, madam.
No, no worry, yaar. No apology. We all are friends. And I can see Amok, Chimote, and everyone. It's like a family, it's our family. And I'm looking forward to see you all in Bhubaneswar. Instead of talking about the ISAR perfection, I want to tell you all, many of you are contesting. Not necessarily all will succeed because there are limited seats, but ISAR needs you all. So those who could not, please, please, please don't get disappointed. Don't leave ISAR. You are willing for election. It means you want to work for the organization. See, it's an honorary work. We are not paid. We take out our very valuable time, and each and every one of you have a huge talent. I know now Dr. Amit Patki is going to take over. He is equally like Nandita, very inclusive, coming with. So whether you are on chair or you are not on chair, like Monica at present is not on a ISAR chair, but she came out with this novel idea and Nandita told, please go ahead, just take Sunita to supervise your work with you and the way she is working. So even if you did not got elected, don't get out, please. And if you have not gone for election, but you just want to be Aanchal, we want the talent to be in the ISAR, to take ISAR even in a smaller cities. And we improve, we optimize the infertility care given in these all tier 2 and tier 3 cities. When I moved during my election, I realized everyone is eager, but unfortunately they don't have either knowledge or the facilities for the due work they can do. So we should all work together and ensure that ISAR become one of the best organization in the globe. We bypass ISHRE, we bypass ASRM, we are huge talent, we have a huge volume of our work, and definitely together we can achieve. I request all of you to come to Bhubaneswar, meet Dr. Amit Patki, who is taking over, and come out with the novel projects, and 2 years down the line, check out. I want all of you. I want all of you to work for ISAR and help me to take the ISAR to another level. Thank you so much, Randhir and Monica.
Thank you.
And I wish all the best to all my friends over here.
And just I'll add one point to you, ma'am. The posts are only for a limited time, 1 year, 2 years. But the work should continue. Therefore, we make that we live ISAR, we are the ISAR.
Fantastic, fantastic.
Yes.
Thank you. Thank you
so much.
Thank you for giving me an opportunity to be all.
Thank you.
Ma'am, ISAR and Foxy are your playground.
IIG also.
Yes, ma'am. We are waiting for it to go from, heights to heights. Only sky is the limit for you, madam. We know it. Because we know Sunita ma'am, we know her talent, we know her hard work.
No, I am always fortunate to have best of the people working with me. No organization is one man or one woman show. It is always the teamwork. Yeah. In my MSR, the way everyone, the Tandans and Sheetal and Rohan and Mohit, everyone has worked so beautifully. That's why 2 years our MSR was rocking. Hi, Bimal. Lovely to see you. And I'm all proud of you. Ekika, I wish you all the best. I really want from small cities enter in.
Ma'am, Aanchal also.
Yes. I saw Aanchal also. I told Aanchal.
There to work.
And Kalpana ma'am, Dr. Kalpana is there.
Yeah, but Kalpana got a Foxy platform also. I am okay. Kalpana wins, Kalpana doesn't win. But Aanchal, yeah, Ekika and Bimal, whoever are contesting, I just... Seema. Seema. All the best, dear. All the best. Thank you, dear. Thank you. Let's work beyond elections.
Yeah, beyond. Madam, we are the for ISAR, and ISAR is our great. And madam, India is going to become one of the best and the largest ART centers, and we will be very lucky. Now also we are lucky, but in coming few years,
in spite of ART, has come. I know the way surrogacy is going on still. Last week, I had a patient, very VIP, came with her bhabhi, for surrogacy. I said, who is doing surrogacy in the family? Who is going to take care? She said, no, you give. I said, are you crazy? It is gone. She said, my best 4 friends, they have done surrogacy this year. What are you talking, madam? I said, I don't want to know also which centers
ma'am.
they have done. I just don't want. But I really on this platform tell everyone, please don't do unindicated, unethical. ART law is very strict. We are not supposed to be in a prison here. Do less cases, but do happy and peaceful practice.
Yeah, ma'am. Therefore, that I all told, ma'am. And I think in some time you're under presidentship and all, we should not come in that position that we have to inform about our black sheeps to the government. That we should not. So that is precaution is best one.
Totally I agree. Thank you, dear. Continue your work.
Thank you for joining, ma'am. Thank you for your blessings. And it is wonderful always to, even I said, ma'am, even for 5 minutes, it will be like sunshine for us. So you have to come. And North is cold, madam. MP is also very cold. So we want some warmth from you, Maharashtra. And
Pune is also cold, but not as cold as North.
Yeah,
but
ma'am.
we are enjoying.
Madam, we are freezing.
I know, yeah. We are enjoying. We are with 20 degrees.
I'm absolutely freezing. Look at me. I'm traveling. And it's so cold out here.
I'm loving it.
Yeah, you are sitting in a humidity, ma'am. I'm traveling. And it's such a cold wind blowing. Oh my God.
Yeah.
It's pretty cold.
मैंने तेरे को देख के अभी जल्दी से पहना, मुझे लगा अच्छा मुझे भी ठंड लग रही है.
मैं रास्ते में हूँ, बिल्कुल अच्छी खासी ठंड है. I mean, yes, we are enjoying. Actually, this is after quite a long time that it's pretty cold.
All of you aspire.
Thank you, ma'am.
Aspire is going to be in August in Pune. All of you are invited. Please block the date. Either first weekend or second weekend of August. Dr. Amit Patki will be announcing it in Bhubaneswar. I invite all of you, and at present you won't imagine I'm doing a meeting simultaneously with the patient, with my event management people, Rajesh Surana and all. He is sitting with me, and between the patient.
Okay, yeah, Surana ji, namaskar.
We do such conferences. My patient is sitting here. Say bye.
Bye, hello.
I'm talking to her also. I'm on webinar and I'm doing my meetings. This is how crazy. But
This
they love
only
us,
Sunita,
and that's why it works.
this multitask only Sunita ma'am can do at one
Every
time.
one of us. Thank you. Bye.
Thank you.
Bye.
Bye.
Bye,
Bye.
ma'am.
Bye.
So I think Purnima.
Yes, ma'am. It was very wonderful talk by Dr. Ashwini, madam. Would the chairperson like to conclude the session?
Yes. A few remarks
Purnima,
after
can
Dr.
I
Ashwini's
just
talk?
speak a word?
Yes,
Just a
Seema.
word.
Yes, Seema.
I have to leave. Can I?
Yes,
Yes, ma'am.
Thank you so much, ma'am, for
Thank
joining.
you so much. It was
having-
wonderful star-studded event, and Monica and Randhir and Purnima, Monica, hats off. I loved every bit of it. And hi Sheetal, Amrita, Ekika, जिसको मैंने hi नहीं बोला, Bima, everyone, hi and bye.
Best of luck, Dr. Seema. Best of luck for your elections.
Thanks, darling. Thank you so much.
Best of luck.
Bye. Best of luck.
Thanks for joining, Seema. Thanks for joining.
क्या बोल रही है?
Okay, so should we move forward, ma'am, for our next?
Yes, please.
Okay, so our next session. It was wonderful talk by Dr. Ashwini, madam. So our next session is on the topic is role of GCSF and sildenafil in thin endometrium. What does evidence say? Speakers Dr. Monica Singh, madam. Our chairpersons are Dr. Indu Kaul, madam, and Dr. Monica Gupta, madam. CV, please. Dr. Indu Kaul, madam, is ex-HOD and Professor of Ops and Gynae, ex-member governing body of AIIMS Patna since 13 to 21, Secretary SAR Jammu Kashmir Chapter, member Academy of Medical Sciences, Fellow ICOG, Fellow IMS, member Editorial Board member, Board, International Journal of Medicine and Public Health since 13, Associate Editor of JK Science, Journal of Medical Association Research, member Ops and Gynae Society of India, member PCOS Society, Indian Life member IMA, more than 30 publication ma'am is having. Thank you, madam, for joining us today. Our next chairperson is Dr. Monica Gupta, madam. Madam is currently working at Daksh Hospital, Alwar. She is West Zone Coordinator of Public Awareness Committee. She has received various prizes, including late Shri S.N. Joshi, brother of Dr. Leela Joshi, Padma Shri and Foxy and 23, President's Rotating Trophy, Dr. Sadhana Desai Population Stabilization Promotion Prize, Organizing President of AlwarCon 23, Foxy Achiever Awarded Best on Yuva Foxy Ranthambore, Tira Master Trainer, Ma'am is Manyata Assessor, and so many awards into Ma'am's credit. Thank you, Madam, for joining us today. We are honored to have you. So now I would like to hand over the session to our chairpersons. Thank you. Indu, Madam, are you there?
Yeah. Do we, yeah, Dr. Purnima, do we have another chairperson?
We have Dr. Monica Gupta, Madam.
Yeah, she's also here. Okay. Yeah, okay, right, fine. So, hello, everyone. So,
Hello, ma'am.
hello,
Thanks.
hello.
Yeah,
So,
invitation, ma'am.
before we start, a huge congratulations to you, Dr. Monica, and your team for organizing such a beautiful, wonderful, and excellent series on this topic, which is series Perfection, which is covering areas of concern and topics that need attention, right? That's important. And I've been hearing so much about this series, and I'm sure you're going to do a good job in future as well. So I would like to thank the team and Dr. Monica, you in person, to invite me for this session of, this excellence, where I'm going to chair this session. So listening to stalwarts in this session like Dr. Durusha, Dr. Rishma, and Dr. Sunita speaks about your, how friendly you are with everyone around. And then it's always amazing to listen to such stalwarts. Now, coming to the topic, I know we're running out of time. So I come to the topic, right? Now, coming to the topic, the discussion is going to be focused on important aspect of endometrium, and that is thin endometrium. And we all know assessment of endometrium is an essential component of assisted reproduction, and its poor receptivity is a major cause of failure of endometrium, one of the major causes of embryo implantation, and critical for successful pregnancy. So our speaker tonight will try to explore what does evidence say about role of G-CSF and sildenafil in thin endometrium. So I take pride in introducing our speaker tonight, none other than Dr. Monica Singh, who is a dynamic member of this fraternity, and her actually introduction.
It's okay. You just introduce me as a nice.
Is already in, but so many.
It's okay, ma'am. It's okay, ma'am. Please, I
sorry.
You can save this time. Thank you so much, Indu ma'am, and thank you so much, Monica Gupta ma'am, for joining me and for sharing.
So, but I know how you awards presently, and then your conference to you that can be added to your series. Now over to you, Dr. Monica, for your deliberations.
Thank you.
Thank you.
Thanks a lot, chairpersons. I'll be just sharing my screen. Yeah. Are my slides visible?
Yes, ma'am. Yes, ma'am.
Okay. So in the next, I want this talk to be very short because we overshot the time, and I want the panel to be longer because the panel, so many people, so many panelists, and my moderators are waiting for the panel. So this is just a simple ESHRE study we presented between 2018 to 21 on the role of G-CSF and sildenafil in thin endometrium. And I want to take you through the background of these therapeutic agents, how we use them in our study, what does the evidence say, what are the conclusions, and take home. Now, we all know that optimal endometrial thickness reflects adequate maturation. This is the key factor for implantation. The endometrium has to be mature enough in order to create an embryo-endometrium dialogue. At the same time, proliferative and secretory changes in the endometrial lining require a complex complex interplaying intrauterine environment, and there the sex steroid hormones and local factors play a role. That is why the therapeutic agents come into play. So many factors have an impact on IVF success. The main variables being the age of the woman, we know AMH, number and quality of embryos, but we have to take into account endometrial thickness, which if less than 7 mm, definitely negatively affects pregnancy rate. Some studies take it as 6.5 mm. Some studies claim to have, pregnancies even at 6.2, for that matter, even 5 mm. But these are rare, and we do not talk about rare. We talk about what is coming in our practice. Growth factors, hormones, and cytokines, which are produced by decidual cells, are involved naturally in this implantation process. Now, what is GCSF? Granulocyte colony stimulating factor is a cytokine, glycoprotein, which stimulates the neutrophilic granulocyte proliferation and exerts immune effect on the endometrium by recruiting dendritic cells, activating the cytokines, promoting angiogenesis, and thereby improving endometrial thickness and quality. As I will explain later, that is the difference between the way GCSF acts and sildenafil acts. One drug will act on the angiogenetic and immunologic pathway, the other drug will act on the vascularity. And I declare that I have no commercial or financial interest pertaining to the subject of this presentation or its content. The study question is, does intrauterine administration of GCSF, that is granulocyte colony stimulating factor, before embryo transfer in resistant thin endometrium improve the endometrial thickness and pregnancy rates in IVF-XC cycles? So whenever we have a presentation in ESHRE, we have to have a study question, and that has to have all the keywords. The study design, size, duration consisted of 86 infertile patients with thin endometrium. All of them were below 45 years of age and recruited between 2018 to 21. All of them had traditional treatment failure with estradiol valerate or hemihydrate, sildenafil, and everything had been unsuccessful in them. These patients were randomly divided into two groups using a computer-generated list after proper written consent. There was a study group of 43 patients who received intrauterine GCSF instillation or infusion, and the control group received the placebo saline before embryo transfer. The primary outcome we measured was the endometrial thickness, implantation and pregnancy rate. The secondary outcome was the abortion rate. So this is the consort statement of the patient flow, how they were analyzed and allocated to intervention group or control group, and there were no patients who were lost to follow-up. So these were the baseline characteristics of the patient. These are very important in ESHRE studies. You have to finish your presentation in about 7 minutes and then leave 3 minutes for question and answers. Now they have come to, I think, 8 minutes presentation and 3 minutes for question and answers. So you have very less time. So these were the baseline characteristics of the patients, which were similar with respect to demographic characteristics like age, BMI, type of infertility, whether primary or secondary, and even the etiology of infertility, whether ovulatory, tubal, male, or unexplained, was similar in the two groups. The hormonal profile of the patients during stimulation was also comparable. This is very important when you're doing an RCT, because then otherwise there will be a bias. So we studied the hormonal levels at the initiation of stimulation on day 2 of the cycle with respect to estradiol, progesterone, FSH, LH, hormonal levels on the day of trigger with respect to estradiol and progesterone. And you can see from the estradiol level of 1600, 1700, both the groups of patients had mature follicles about 8 to 9 on the day of HCG trigger. Now remember, endometrial thickness on the day of trigger was 6.4 and 6.4 mm in both the groups. So what did our study do? The study group, which were about 43 patients, received intrauterine infusion of 300 microgram in 1 ml volume of GCSF, which comes in a pre-filled syringe, and the control group underwent instillation of saline. GCSF was administered by an intrauterine IUI, simple IUI catheter by slow instillation, and I prefer a curved long IUI catheter. I don't prefer state catheters on the day of HCG administration. And if the endometrium did not reach at least 7 mm within 48 hours after GCSF, a second dose was administered following oocyte retrieval immediately after the pickup. So the second dose of GCSF is brought to the theater by the by your nursing staff or assistant, and you can simply load it in an IUI catheter, and after doing an oocyte retrieval, just put it there. Ultrasound assessment was used for measuring the thickness of the endometrium before and after GCSF. All scans were preferably done by one operator using a good transvaginal probe. It didn't matter whether you used a 2D probe or a 3D volume probe. And as we all know from TVS knowledge, endometrial thickness is measured in the sagittal, mid-sagittal plane from outer to outer edge of the endometrial myometrial interface in the widest part of the endometrium. Never measure the endometrium in the transverse plane. GCSF was first used by Gleicher in 2011. He did 4 patients. He got pregnancy in all 4. So he proposed a methodology of stimulating endometrial growth using intrauterine instillation of filgrastim or GCSF. This is, as I told you, a cytokine. So this is generated by a large group of body cells. You get it from bone marrow, from stromal cells, from fibroblasts. It is hematopoietic in its action, stimulates the formation of neutrophils and stem cells in the bone marrow, which in turn cause proliferation of several body tissues, including the endometrium. And there are immunological activities of the GCSF, which include dendritic cell recruitment, enhancement of T2 helper cells, which are the good helper cells, activation of the T regulatory cells, and proangiogenesis. So GCSF may increase the thickness of the endometrium in patients who have got refractory thin endometrium and other methods have failed. So remember from the study by Sudha ma'am and Rishma ma'am, they all said you go to GCSF when traditional treatments with low dose aspirin, vaginal sildenafil, even PRP has failed. So it increases, and here vaginal sildenafil is different because it increases blood supply of the uterine arteries and myometrium. It doesn't actually expand the thickness of the endometrium. And we have alternative treatment like tocopherol and pentoxifylline, but these therapies have to be used for a longer duration of time. Our inclusion criteria were women aged 18 to 45. None of the patients were above 45. They all had previously cancelled at least one cycle because of thin, unresponsive endometrium. They had inadequate thin endometrium in the previous cycle on the day of HCG. There was lack of contraindication for GCSF like sickle cell disease, chronic neutropenia, malignancy, renal insufficiency, upper respiratory tract infection, pneumonias, and congenital fructose intolerance. And naturally, we also excluded Asherman's, fibroids, polyps, or any sort of intrauterine pathology. So these were our results. This is a very important slide. When you present internationally, you have to tell the results, and your results are really scrutinized very hard. So all the questions which are asked to you after your presentation in ESHRE or ASRM are based on your results slide. So the number of embryos transferred, as you can see, was same in both the groups. Endometrial thickness before intrauterine instillation was 6.43 mm in the study group and 6.43 in the control group. But the endometrial thickness after intrauterine instillation of the drug was 8.11 mm in the study group, GCSF group, versus 6.67 in the control group, which was statistically significant. And this was found out by a statistician who was working with us. Similarly, we found a significantly higher implantation rate of 22% in the study group versus 8% in the control group. We found a pregnancy rate of 33% in the study group as compared to 14% in the control group, but an abortion rate was also higher in the control group, but this was not statistically significant simply because when it is a thin endometrium, you are likely to have first trimester abortions. So these are all the findings of the table, which I've already told you. Our conclusion is that endometrial instillation of GCSF may be effective in expanding chronically unresponsive thin endometrium, which is resistant to conventional remedies. This treatment needs more multicentric trials to assess its potential in improving implantation chances in IVF-XC cycles, thereby improving the pregnancy rates. And uterine perfusion or subcutaneous injection, another route of GCSF, represents a promising new tool for intractable problem of thin refractory endometrium. But personally speaking, I have not found as good rate with pregnancy rate with subcutaneous GCSF as the vaginal route. So this is all about GCSF. We've already told you, and you can even combine GCSF with estradiol, sildenafil, depending upon your preference, because these are all empirical studies. And interestingly, the clinical pregnancy rate shows more statistically a significant improvement in those patients who belong to Asian ethnicity.
So you're done, Dr. Monica, right?
I don't know, my slides have stopped moving, ma'am. There's a
Why is
confusion.
it? Yeah.
1 second. Can the tech support help me? I don't know what has happened. Yeah, it's moving.
Oh, yeah, it's moving.
I'll just take 2 minutes more.
Yeah,
with your
sure.
Our study is not without limitations. So again, you have to tell the limitation. There is a SWOT analysis nowadays, SWOT, as all teachers must be knowing: strength of your study, weaknesses of your study, then the, what is opportunities and threats. So S stands for the strength of my study, W stands for the weakness of the study, O, what are the opportunities to do more work, and what are the threats from your inference. So we did not have a large number of patients. We just had 86 patients. The main strength of the study was the RCT design, with which we could evaluate the efficacy of intrauterine GCSF administration versus placebo. But definitely more RCTs are required to establish the best route and dose of this drug. And these are the implications, the research and all. And coming just a word about sildenafil, I've already talked about. This is the drug which acts by the nitric oxide production. You can all read about it, how it produces nitric oxide. So it causes vasodilatation and enhanced blood flow. So the main effect is to improve the endometrial blood flow, and directly it will go to the spiral arterioles, increase the vascularity, reduce the, the vascular myometrial contraction, improve the uterine blood flow. Your RI and PI of the uterine artery will improve, and you will get a better implantation rate. And all of you have already blessed me for ISAR Managing Committee elections. So I am really blessed. And thank you all for a patient listening. Thank you.
Thank you, Dr. Monica. It was an excellent talk from your side, and excellent study you have conducted. As we all know, the uterine factor is very important in any of the pregnancy. Either it is a ART pregnancy or a natural conception. Many a times the person like us who are not into the ART, they miss many of the things. And it is really an eye-opening. And I should say it should be, these type of series should not only for the ART persons, it should be for other persons also. Because many times we do the things which are going to affect your results. When we are doing myomectomy, we are not into that idea that it is going to destroy so much of the endometrium and later on the pregnancy will become difficult. And the role of DCCF is very important, and it will lead to more of the conception rate, more the take-home baby rate, and more successful ART. And I really congratulate, and I wish you should conduct more of such a study and should give a beautiful guideline for the others to work also. Thank you very much.
Thank you so much, Monica, ma'am. Thank you so much. So now,
thank you, Dr. Monica, for the wonderful presentation. And what is best is that this original presentation, it's huge. And as Dr. Monica said, then we are looking forward to presenting series on this study. As you yourself acknowledge that the number is little less, and then maybe in future you'll work on it. But then there are studies which tell us about this, and it has a huge promising background. So let's see how it works in India. Anyway, thank you everyone for your.
You, ma'am. I'm really honored to have you as a chair, and Dr. Monica Gupta, and it's a pleasure to be amongst all of you. And I would like to, keep connecting with you, keep troubling you later also.
Sure. All the best, all the best. We have all voted for you, by the way.
Thank you so much. And I would urge people who are left out, people who are super busy, to please devote just 5 minutes of your time to ISAR elections in whichever city you are. There are pockets of people who are ISAR members, but they don't know their membership number. Some people have forgotten which email ID they registered with. There are some elderlies who are not very comfortable with the registration. Please feel free to contact me, Purnima, and Manisha. We are 24/7 there for you. We will take out your number. We will do the voting for you. Even if you say that don't vote for Monica, we'll even do that. But we will do the election process for you, because it's very important that we vote. Because like Sunita madam said, when you want to enter a committee or you want to do Foxy like Asha ma'am wants, I want, later Manisha will want, we want to get into the organization so that our voice is heard. We don't want the money or the glamour, but we want our voice to be heard. What we want to say, we want to make an impact. So that is the feeling of every human being, to do what is right, and that right thing should be heard. Thank you so much.
All the best.
you so much, ma'am, for such a wonderful talk. Now let's move forward for the panel discussion. Dr. Manisha, madam.
Yeah, thank you so much, Purnima. After all the wonderful talks and discussions, let's move on to the panel discussion. And for panel this session, we have with us Dr. Amita Tandon and Dr. Aditi Tandon, and the topic is demystifying thin endometrium. Dr. Amita Tandon, madam, she's a fertility and IVF consultant at Chembur, Vashi. She is a member of MGS Youth Council member. She's the member of Oxy Sexual Medicine Committee, member of Oxy Youth Talent Promotion Committee, member of MOX Infertility Committee, and she has done various fellowships, presented various papers and various awards to her credit. I welcome you, ma'am. Thank you for joining. Next moderator we have with us Dr. Aditi Tandon. She is again a gynecologist, laparoscopic surgeon, fertility specialist at Chembur, Mumbai, Vashi. She has done fellowship in ART, ex-assistant professor at DY Patil Hospital, Nehru, trained from AMAS, Mumbai, and she has various awards to her credit. Thank you for joining, Dr. Aditi. Panelist we have with us Dr. Anchal Garg. She is director of Colors IVF Fertility Center from Lucknow. She has done fellowship and done masters in reproductive medicine. She has a vast experience of more than 10 years. Thank you for joining, Dr. Anchal. Next, Dr. Amok Chamote, sir. He is the Joint Organizing Secretary of PertiQuest 2019 Nagpur. He was the member of SR Jaipur, operated faculty various workshops and various awards to his credit. Thank you, Dr. Amok Chamote. Welcome. Next, Dr. Vimal John is the director and senior consultant of minimally invasive aortic at Credence Hospital, Trivandrum, Kerala. He is ICMR NIRH Intermediate Research Investigator and Reviewer of Journal of Minimally Invasive Gynecology. Welcome, Dr. Vimal. Dr. Rika Singh, she has held various posts. She's been the secretary of MAU Ops Gynae Society, member of Management Committee ISAR, executive member of UP ISAR State Chapter. Welcome, Dr. Rika. Is she there?
Thank you.
Yeah. Next, we have with us Dr. Kalyani Srimali. She is senior consultant and reproductive medicine specialist from Nova IVF Indore. She is in masters in reproductive medicine and she has done vast, immense experience at various centers. And she has presented various papers and has been awarded various awards. Welcome, Dr. Kalyani Srimali. Dr. Neelam Bise, next panelist is, she has various professional attachment as Chief IVF Consultant at ACME Fertility Mumbai, Scientific Director of ACME Hospital Mumbai, ex-assistant professor KEM Hospital Mumbai. She has been practicing IVF since more than 10 years now. Welcome, Dr. Neelam. Next panelist is Dr. Shakshi Singh. She has done fellowship in reproductive medicine and she has a vast experience. She has also worked at Johns Hopkins, Baltimore, USA. She has been secretary ISAR Jharkhand chapter and joint secretary ROGS in 2022 and 2023. Welcome, Dr. Sakshi. Next panelist we have this Dr. Sheetal Savankar. She has done diploma in reproductive medicine and cosmetic gynecology. She is the director of Avisa and Fertility Center, and she has been the managing committee member of MSR in 2023 and 2025. She has been the recipient of MOGS RD Pandit Award. Welcome, Dr. Sheetal. Next panelist is Dr. Shivani Joshi. She has a diploma in reproductive medicine. She is working as a medical director and consultant at Total Fertility Solutions IVF Center in Indore. She has been a certified clinical embryologist. She has presented various posters and paper in various conferences. Welcome, Dr. Shivani. Next panelist is Dr. Sonali Agrawal. She is again a consultant and laparoscopic IVF specialist at Agrawal Hospital Research Institute, Gwalior, MP. She has held various positions as executive member IFS, Joint Secretary Gwalior Ops Gynae Society, Treasurer Gwalior Ops Gynae Society, and she has been instrumental in organizing various live surgical workshops. Welcome, Dr. Sonali. Last but not the least is Dr. Supriya Hajela. She is consultant and director of IVF Center at Bhopal, Hajela Hospital. She has been a senior lecturer at the School of Embryology and Assisted Technology. She has been the recipient of ISAR Youth Icon Award 2023. Welcome, Dr. Supriya. Over to moderators for further session now. Thank you.
Thank you. Thank you for that kind introduction. Yeah, at the outset, I would like
Your voice is going.
Yes, just give us a minute.
Are you logged in by 2 devices?
Yeah, hello. Is it better now?
Yeah, better now. Yeah.
Yes. Sorry about that glitch. At the outset, I would like to thank Dr. Monica to give us this opportunity, and best wishes to her, Dr. Randhir, and all the other people contesting for the ISAR elections. We have a young, dynamic panelist today. Welcome all panelists, and we're going to be discussing thin endometrium. I think we've already covered most of the theoretical aspects beautifully by the previous speakers. So we'll be sticking to the practical aspects as an introduction. Yeah. So that's the picture that we would like to see when we are stimulating our patients either for an IUI or during an ART cycle. We want a good endometrial thickness and also the appearance. We know that it increases during the follicular phase, and it changes from hypoechoic trilaminar to a compact hyperechoic look post-ovulation. And increased probability of a live birth. Of course, there is an invasive way to check endometrial receptivity by the ERA. We still don't know whether it is conclusively beneficial to do ERA or not. We need more studies to kind of, suggest that, but non-invasively, of course, we can check the endometrial receptivity by a 2D ultrasound, by checking the thickness, by checking the pattern, by checking the volume, by doing a 3D ultrasound, and also the Doppler of the uterine and subendometrial blood flow. So each of the panelists, how thin is too thin? Do you have a cutoff? What do you think is a thin endometrium?
Yes. May I?
Yes, Dr.
Hi,
Raman.
Aditi.
Yes.
Yeah, hi.
Yeah.
At the outset, I'd like to thank Dr. Monica, Aditi, and Amrita for inviting me to this panel. So, personally, in my practice, we have got pregnancies even with the 7mm endometrium. So, against the consensus and what the research says, that less than 7 is thin. But what we feel is less than 6 is what is thin for Indian population at least. So anything between 6.9 and above is a good endometrium, and we do get pregnancies that, depending on the vascularity as well as the subendometrial blood flow, the uterine artery blood flow, and if you have ruled out arthritis, then even a 6.9 to 7mm endometrium is good enough. So for me, less than 6 is too thin.
I think
Less
I
than
agree
6.
with Amog. I think less than 6 is something which is a cutoff, especially when you're doing like a natural cycle or a modified natural cycle where you have a good trilaminar endometrium with a 6mm endometrium. I've got multiple patients who've got 6mm and we've transferred and we have got pregnancies with a good flow, and yes, that should be good.
Right.
Yeah,
Would any
I think that's what is right. It's right.
Your voice is crackling.
Also, so probably what she said, I mean, at 6mm, endometrium and close flow.
Not able
Can't
to
hear
hear
you. I can't hear you.
Your voice is breaking, so it's difficult to listen.
Okay, so meanwhile, probably I'll just pitch in with my experience. We usually keep it at a minimum of 7 to 7.5. Anything below 7.5, we talk to the patient and then explain, this is what the stats say. There's a slightly lesser chance. But consistently, if if her endometrium reaches like multiple cycles, we try with HRT. And if it's still around that 7 to 7.5, we don't, wait till she catches up to beyond that. So 7.5 above is comfortable for us. 7 to 7.5, a little bit of talk to the patient. Below 7, we hold it as far as possible.
May I add something here?
Dr. Aditi, may I add something to this?
Yeah. So what I was saying is, of course, we know that when we start progesterone, the baseline of 6 millimeter, less than 6 is absolutely thin. Between 6 to 9, we would want to try adjuvants. But if it is a second, third cycle, and we see the endometrium, we're monitoring, and if the endometrium is static, that is also an important factor where we label the endometrium thin, even if it is 6.97, and we monitor it for some time, but it is not growing further. So the static endometrium is also an important factor which we should, I think, add as a criteria of thin endometrium.
Okay. Yes, Dr. Supriya?
Yeah, I just want to add one thing, that even after giving adequate estrogens for a limited time period, and still you have thin endometrium without compromising the pattern of the endometrium, I would like to go ahead with 6 mm. Because the pattern also matters. It's not only the thickness, but if you have a good trilaminar endometrium and then you see that the pattern of the endometrium, you're losing it, it's better that that is the time, it's the limit probably, and after this it's not going to react to your treatment line. So I think that point can be taken as the point for the particular patient.
Absolutely. I think most of us agree that, so the studies show that 7 mm is also, you don't need to try, cancel a cycle even if it is 6 mm with a good trilaminar pattern and the blood flow is good. Yeah. So, of course, you need to rule out causes of a refractory endometrium. They could be prior surgical DNC, partial ablation because of a myomectomy, post-Strassman surgery, or infections, or other multiple reasons why the endometrium could be refractory. And these causes need to be ruled out before you. Yeah. So let's move on to the case discussion. A couple visits your clinic. Wife is 32, husband is 35, unexplained infertility, and you're planning an IUI for them. You stimulate using clomiphene and HMG, but on day 12, you see a dominant follicle of 17 and an endometrial thickness of 6 mm. Would anyone of the panelists like to cancel the cycle?
No.
No.
Okay, so I think unanimously 6 mm with a good pattern.
Internet is not very good, I guess. Patchy.
Is it better now?
Yeah, now we can hear you.
In between, actually, you are getting disconnected in between.
No, that's because there is somebody else, making noise in between. So the mic shift to them. That's the problem.
So I think you need to pin yourself.
No, others can mute unless when they're talking.
Yeah,
Right?
I think the panelists can mute unless they wish to speak. Yeah, so I think unanimously we agree that we will not cancel the cycle, and studies also do suggest that canceling the cycle, there is no change in the pregnancy rate based on the endometrial thickness.
Actually,
So how will you proceed?
Aditi, especially in an IUI cycle, even if your endometrial lining is thin, there have been multiple studies which have been done, especially in an IUI cycle, even if your lining is 5 millimeters or 6 millimeters, it does not affect the pregnancy rate. So there have been studies which have been done.
Exactly.
Actually, I want to add one more thing to this. I mean, the follicle is 17 millimeter. We can wait for a day or two also.
Yeah.
So 17 millimeter, and then we can see that endometrium also might grows up by that time. 17
Right,
millimeter
so-
doesn't mean that it's mature.
Right.
Correct.
So
And
if we
look
see
for
the site, the
pattern
patient
also.
has, sorry, please go ahead.
So we look for the pattern also, and after 2 days we can see for the blood flow also. So if it is increasing and it is adequate zone 3 vascularity, then we will move on.
Right. So
In the
in
next
any IUI with CC cycle, it is expected to have a thin endometrium before the ovulation takes place. So even after ovulation, if the endometrium is thin on the day of IUI, you can add estrogen for these patients.
Yes.
At 2 milligram BD or TDS, depending on if the first cycle, then 2 milligram BD is a adequate enough dose. If it is a subsequent IUI, maybe a second or a third IUI with a refractory or a thin endometrium, then you increase the dose to 2 milligram TDS or even QID in such patients. And they do respond to the estrogen supplement given. And many a times with a trigger also, you get a good epidural thickness by the time you're doing an IUI.
Correct. Okay.
In the next cycle, good evening. In the next cycle, probably instead of clomiphene, we can use letroz along with the gonadotropin, so that the lining is not affected that much. And also, we can do this that when the patient when the dominant follicle reaches around 14 mm, we can add cetrorelix so that there is synchronization between the endometrial thickness and the follicular growth in this particular patient.
I want to defer for the I'm sorry, I mean, as far as cetrorelix is required, yes, as what Anchal says, if you think that this thin endo is because of CC, and I mean, though we should not cancel this cycle, if we are canceling this cycle, then yes, we can use letroz in the next cycle, and with one single follicle at 14 millimeter, I am not very much sure that cetrorelix should not be added. I think with that only you will get the good endo. No use of adding cetrorelix with one single follicle growth unless we are sure that it might cause so much of hyperstimulation that we need to suppress it. Probably, I just want an experience and opinion of
Maybe
other
the need of
panelists.
cetrorelix. I agree with Ekita. One follicle, cetrorelix will have no role.
No role. So
that is not.
probably with one follicle, no. When that's the message, letrozole, and you can wait till the follicle grows even till 20 millimeter. Many a times with them, even with CC gonad and letrogonad, the maturity of follicles come bit late. So by the time the endometrium might grow. So just be patient, and then we can think of doing
No, here
planning the rest of the
cetrorelix is not being added to prevent OHSS. It is just being added to have a synchronous growth of the follicle as well as the endometrium, so that both of them reach maturity at the same time.
So
Preventing
So
the
if I may,
Anjal, it is only after when the follicle start maturing, there is 2/3 of the flow, that much estrogen will come
Right,
so that the endometrium grows. So you cannot synchronize both of them. It is only after 2/3 of the growth of the blood flow towards the follicle, enough of estrogen comes to give it to the endometrium, and always endometrium grows 1 or 2 days after a follicle growth. I mean,
Right.
the growth of the endo comes like that. So how, I mean, I've not gone through that study. There might be some studies which Anchal is talking about. Probably, Amol,
So-
what is that you have to
So
say?
there's a wonderful paper by Dr. Sonal Panchal regarding the perifollicular blood flow. So 17 millimeters should not be the cutoff. You look at the perifollicular blood flow. When the perifollicular blood flow is, say, around between 50 to 70% of the perifollicular flow is good, and the resistance index when it goes below 4.8, that is the time you give the trigger, and you can achieve a good ovulation. And are assured of a good oocyte. So that is what the paper says, and that is what we also personally experience in our own. We don't have a specific cutoff. Even if follicle reaches 20 or 21 millimeters and the perifollicular blood flow reaches at around 50 to 75%, that's the time we give the trigger. And eventually, the endometrium, when there is a good perifollicular blood flow, the endometrium does catch up and it reaches beyond 8 and 9 millimeters before the ovulation.
And it doesn't matter in this patient. Any which ways the lining is 6. IUI doesn't really matter. With the trigger, with the follicle rupturing, I think it should work. We don't have to think so much about it.
It will come up. It will definitely come up. Yeah.
Absolutely.
Now, this is the paper that I was talking about.
Yeah. We've also spoken of, Dr. Amog has spoken about giving estrogen as an adjuvant. Anyone who would like to use any other adjuvants like maybe sildenafil or anything else for this cycle?
You can give sildenafil.
No.
Not
This
for
particular no. Not
in the IUI
to
cycle,
add-
you're asking Aditi?
I would like to add a vaginal estrogen. If it is a thin endometrium.
I would rather give vaginal sildenafil.
So if you see,
yeah, even I would rather get vaginal
I
sildenafil.
would rather get vaginal sildenafil instead of estrogen, because we know the more obvious cause of thin estrogen is probably CC in this patient and not
Yes.
blood flow. So if you see the papers, none of the adjuvants work. If you see the go by Cochrane rule, nothing
We are
works.
all just trying. So
It
nothing,
is
then
all
that
trying.
nothing works.
So if it is the first cycle, just go according to your protocol that you use in your own practice. If it fails, if there is no increase in the endometrial thickness, then you need to investigate the cause of the thin endometrium. Sildenafil or vaginal estrogen or even oral estrogen generally will be supplemental, but is not 100% sure that it will work. So you need to
Yes,
find the cause of that refractory growth of the endometrium rather than just trying out things.
I agree with Amol. Here, this is a natural cycle. Like we are planning for ovulation induction and spontaneous pregnancy. So we need to relook into the infections, probability of endometritis, micropolyposis, and work towards it maybe by next cycle. And then once we correct those pathologies and then give ovulation induction, that's a better plan.
I think it was CC and HMG cycle. It was not a natural cycle, right?
Yeah, it was CC cycle.
Yeah, it's a CC and HMG cycle, and
proper CC and HMG cycle. So I think whatever works.
Yeah, absolutely. So that's what the studies also say, that the thin endometrium does not really impact the pregnancy outcomes in ovarian stimulation cycles. And of course, the patient needs to be counseled that yes, this is the problem, and maybe in the next cycle, maybe your chances of conceiving may be lesser than expected. Next cycle, maybe we can try, letrozole with clomiphene and maybe adjuvants. But according to studies, there is no recommendation that these adjuvants really work.
In this particular patient, this endometrium will come up after 1 or 2 days. So in this patient, we may not need these adjuvants. But yes, otherwise, like we have tried PRP, and in some cases, it works wonderfully.
So I believe Dr. Aditi and Dr. Amrita have a case regarding PRP installation also.
We will be discussing.
PRP. So I have a few interesting points regarding that. So we'll discuss then.
Yes. Yeah. Sorry. Yeah. Moving on to the next case, Dr. Amrita will be taking over. Yeah.
We still have echo.
Yes. You both are sitting next to each other.
I think
I think one needs to mute.
yeah, so Aditi has muted, but it's still
Ma'am, you can shut down the
use
use
log
Dr.
out and then
Aditi's
you
screen
can
itself. You can use Dr.
yeah, I
Aditi's
think this
screen.
is better because that was
Better now.
can you hear me?
Yes, yes.
Can you hear me?
Yes.
Yeah.
So so I think we've discussed enough about IUI and we have practical points of how to proceed with if you do face thin endometrium in a patient who is undergoing stimulation for IUI. But of course, I think it is more challenging when a patient is for IVF. And so that's what the next case would be. So this patient, she's 38 years old. She's undergoing her first cycle of controlled ovarian hyperstimulation. And on the day of trigger, her endometrial thickness is again 6 millimeters. That seems to be like the golden number today. And the pattern is triple layer. So we do the pickup and we retrieve 5 M2 oocytes. So in this particular case, I would like, I think Sheetal, can you take up? What will you do? Will you proceed with a fresh transfer or would you freeze all the embryos?
See, in today's India, I generally don't do fresh transfer. So from that point of view, I would not go ahead with a fresh transfer. Plus her lining is 6 millimeters. So anyways, in this case, especially, I would prefer doing the pooling of embryos. So again, that is what is my take on this patient. But then also M2s are only 5. So depending on what her plan is, whether she wants to take the fresh transfer and go ahead as the next transfer. So it depends on the patient also. So I have to counsel the patient first what she wants. If she's keen on going ahead, if she's okay with the chances of fresh transfer being around 20 to 30% of pregnancy, and then going ahead with a donor egg. So it all depends on what the patient wants also. So if she's okay with pooling, I can, because again, 6 millimeters triple line, I think is okay to go ahead with if the embryos are good. Or if the embryos are very good, then I will freeze them, depending on what they are. Or if the embryos are okay, then I will go ahead with the transfer. And then if she's okay for a donor egg cycle, that is my plan.
Yeah.
Again, it varies from patient to patient and it varies from consultant to consultant.
I think that's what the challenge face, in practical life, where the patient's decision also matters.
Yes.
Does anyone want to add to what Sheetal has said? Anybody?
Yeah. Hi, good evening, everyone. Kalyani here. Sorry for joining in late.
Hi, Kalyani.
Hi. So happy New Year to you guys, first of all.
Wish you the same. Thank you.
Okay. So coming back to the case, the first is, Aditi, I would like to know, because usually when we plan an IVF for such patients, normally we have done one cycle of natural cycle, or we have monitored her, or we have gone through her papers to understand basically if she has got thin endometrium or endometrium of 7 and 8, and it's only this IVF cycle that she's making an endometrium of 6 millimeter. So in case if my previous charts are showing that she grows an endometrium of 7 to 8 millimeter, probably I'll go ahead, freeze the embryo and do the frozen embryo transfer. But if the previous cycles have also shown that it's 5 millimeter, 6 millimeter, then we have worked out everything for her. And her progesterone levels for this on the day of the trigger is all okay and good embryos, probably I'll go ahead and do the transfer. So that's my take on it. And of course, if it's a pooling cycle, then we go ahead and plan the second cycle. In between, you do the endometrium check and all.
Absolutely. I think that's a very important point. We have to go back and, look at their papers if they've undergone IUI cycles, ovarian stimulation cycles, to check if the endometrium grew in the previous cycle. Yeah, Amol, please go on.
Yeah. So what we need to first of all analyze is, with controlled ovarian hyperstimulation, we are getting 5 M's. That means there must be other small follicles as well. So if we take that each M2 is giving us an E2 level of around 250 to 300. That means total there is around 1000 to 1200 E2. And even such high levels of E2, the endometrial thickness is not going beyond 6 millimeters. That means this is in refractory endometrium. And even after, even if we see that we have maybe a good D3 embryo or a day 5 blastocyst, the lining would not grow beyond 7 or 7.5 millimeters with poor vascularity. So in such patients, I would not like to do a fresh transfer. I'll wait, I will evaluate the patient, and then when I find out that if it is a refractory endometrium, then take management steps for managing it, and then only go ahead with the frozen transfer.
Yeah, actually, I also
Agreed,
want to
agreed.
add to Amok's point. I mean, if I'm getting 5 oocytes, 5 M2 in this patient, and I'm getting 6 endo, if it is trilaminar, then okay, I can think of it as good. But otherwise, if you're getting 5 M2s, then there is enough of estrogen to give you a good endo. So if you're not getting a good endo, then chances of it being having any kind of endometritis is more. So probably in this patient, I would like to freeze, check for the things, and then decide in the next cycle. And besides, she's 38, I might convince her for NICS also. So probably in this case also, I would definitely would like to freeze her. With 5 and M2, 6 endo, I mean, there are a lot of chances that it could have some other reasons besides.
I think when the patient is 38, if her AMH is low, if you're kind of thinking that she's going to get less number of oocytes, you will pre-evaluate her beforehand. Like maybe you will plan a hysteroscopy because you are going to kind of thinking beforehand that you might have to plan a fresh transfer, right? So I think you will be evaluating her beforehand only. So sometimes because the role of fresh transfer is only left in cases where you are thinking about when there are poor responders, right? So I think you will be mentally prepared also that in these kind of patients, you might have to think for a fresh transfer. So in such patients, I think you are a little mentally prepared also.
I agree with Sheetal, but the way I would put it is on the day of trigger only, you would know your progesterone levels.
Yes,
There is
you'll do that evaluation also.
Applebaum score to know the vascularity, the movements, and the pattern of the endometrium along with the thickness, the blood flow to the myometrium, uterine blood flow, and the endometrial blood flow. And along with that, if you know the patient has long years of infertility, has multiple procedures done before, in such case, when you have got 5 oocytes at 38 years of age, if you know the history of long-standing infertility, it is always advisable to do a pre-embryo transfer hysteroscopy, freeze the embryos, do the hysteroscopy, and then go for embryo transfer.
Yeah, so if we go vice versa, when I do my scans, the first thing I see is the uterus in a IVF cycle. Depending on the trilaminar morphology and the size of the endometrium, we can predict if we are going to get good oocytes or not. Many times, even an M2 oocyte might have a nucleocytoplasmic asynchrony and they may not fertilize. So this is also an indication, and plus she's 38 years old. So there are chances the oocyte quality may be bad and we need to evaluate further. Go back in history and check.
Yeah, in this patient, since the like I agree with the co-panelists. So if the pattern is triple layer, then in this patient we can go for a day 2 transfer. And since the ovarian reserve is also very less, so I might go for a fresh transfer if a progesterone level is below 1.2 on the trigger day. And in case the progesterone level is on the higher side, then definitely freeze all, and then after hysteroscopic evaluation or monitoring in the next cycle, we can go for a transfer, a frozen embryo transfer.
So I'm glad that the panelists are having a very healthy discussion and different views on managing the same patient, which is the point of having a panel discussion. So like we said, in IUI cycles, we don't expect a lot of difference with a thin endometrium, but what are the expected adverse effects of thin endometrium on implantation rates and pregnancy rates and even miscarriage rates in IVF cycles? So would anybody want to take that up?
In IVF cycles, in IVF cycles, I think with thin endometrium, there are enough and more studies stating that there is a negative impact as far as abruptions and preeclampsias and preterms are concerned. Although there are very limited studies stating thin endometrium along with the first and the second trimester obstetric complications. That still hasn't been read yet. But then thin endometrium, yes, it leads to various obstetrical complications in the later gestation.
Right. So yes, there is definitely an adverse effect on the implantation rates, the clinical pregnancy rates, the live birth rates, and a higher chance of miscarriage when patients of thin endometrium conceive.
And
So
if they do carry beyond 12 weeks, then there are very high chances of preeclampsia.
obstetric complications as well. Yes. So now moving on, like most of our panelists agreed that we would prefer to freeze all. So we did have 2 good quality blastocysts formed on day 5 when we froze them. Now the patient is for a FET cycle in the next subsequent cycle. So how would you basically prepare this patient? What would your preferred method of endometrial preparation be? Dr. Neelam, could we hear from you?
I'm sorry, I just got a patient. I didn't hear your question.
So basically, we froze the embryos, like you said. She's for an FET. So what would your preferred method of preparation be? HRT or modified natural cycle, what would you prefer for this patient?
If the patient is ovulatory and she is young, the natural cycle embryo transfers give very good results, preferably with lesser medication, more physiological. But if the patient is higher age, she is not having a good hormonal profile, her ovulation patterns are not good, or she is going for a donor-egg cycle, then of course you have to go for a modified, maybe HRT cycle. Only what I would try to see here is nowadays we're giving higher doses of oral estrogen, and the doses keep on increasing. And in an elderly population, it is a liver load. Even if we are giving hemihydrate or valerate, it is a systemic absorption which we are looking at. So I usually try to add up with a transdermal estradiol, maybe 8 applications in a day, along with the oral estrogen. That would be my preferred way of starting this ET preparation.
And has anybody used vaginal estrogen for FET cycles? The hydrate vaginal estrogens for preparation of the endometrium?
Yes, people have come with effervescent tablets, but I have not personally tried them.
Okay.
So I would still go with the HRT cycle for this patient.
Okay.
Because in natural cycle.
For not using the modified natural?
So she is 38 years old. With 5 M2s, she had just 2 blastocysts. Oocyte quality is one issue. Secondly, with levels of estrogen, her endometrium was not good. So here comes the role of estrogens and sildenafils and elarginins and heparins and all the additives that we use.
We'll be talking about that. I will be asking each one of you what are your preferred and favorite adjuvants. But here I'm just asking about the preferred method.
HRT.
I think I'll also go for
I'll go with
HRT.
HRT in this cycle.
The first
So
cycle
then
would
we
be
have a
HRT.
divided panel. Yeah, but yes, most are saying HRT. Let's see what the studies say. Now, this is, I know, a simple question, but does the embryo quality actually matter in a case of thin endometrium? Do you see better results with in a patient, say, who's undergoing an oocyte donation and has good quality embryos versus in a thin endometrium versus a patient who would have poor quality embryos with thin endometrium? So, anybody
Yes,
could take that.
definitely. Yeah, quality of embryos matter a lot.
So, which is exactly what the studies also say. So I'll just quickly go through this. I think all these studies have been kind of shared in the earlier presentations, where this was a review of pregnancy rates after IVF in Human Reproduction Update, where the endometrial thickness, of course, cannot be used as a parameter to decide on cycle cancellation or freezing of all embryos. But there is a trend towards lower ongoing pregnancy rates and live birth rates for women who have an endometrial thickness of less than or equal to 7 mm compared to those who have an endometrial thickness of more than 7 mm. And endometrial thickness can give us a probability, but cannot be predictive of pregnancy. Fresh or frozen ET, because of the adverse effects of controlled ovarian hyperstimulation, elective freezing of embryos with subsequent transfer in an HRT cycle is advocated. Various studies have shown that as the endometrium, the thickness increases between 9 and 14 mm, when you start progesterone supplementation would be an ideal endometrium to kind of have a better implantation rate and pregnancy rate as compared to an endometrial thickness of 7 to 8. There was a retrospective study which showed that when the pregnancy rates in patients with endometrial thickness of less than 6 mm of 35 patients, only 3 pregnancies were seen and only 2 patients delivered. So, but incidentally here, but it was higher in the FET group. And a recent study, a similar study also said that the implantation rate and live birth rates at a endometrial thickness of 5 mm in fresh versus frozen. So frozen transfer cycles, the implantation and pregnancy rates were higher compared to the fresh cycle.
So, if I may,
Yeah.
so as Dr. Neelam said, if it's a young patient, we can go ahead with a natural cycle or a modified natural cycle. But
Okay.
for a patient who is 38,
Yes.
Sir, you're muted. Muted.
Amol, we can't hear you.
sorry, can you hear me now?
Yeah, now we can hear you.
Yeah, so for a patient of 38 years in Poseidon 4, HRT cycle is what I would go with.
Okay.
I think
And
it
that will give
doesn't matter. I think as long as the patient is ovulating, it is, and if the endometrial lining is not forming with HRT, I think you can go ahead with the modified natural cycle is without any medications. So natural cycle as such is a very difficult thing. Nobody actually does it. So if you put antagonist also into the picture, or you put HCG also into the picture, then it becomes modified natural. If you're putting letrozole into the picture, then it becomes a mild stimulated protocol. So natural cycle, nobody actually follows. So we have to call it either modified natural or you have to call it stimulated cycle. So even ovulated patient, even at 38, you can do it as long as the patient is ovulating, is what is my thinking.
Yeah, actually, I will also go with Sheetal. I mean, this patient didn't have a good endo, but it
Yes.
is being seen the endogenous estrogen always have a better effect than the exogenous estrogen. So, giving for me, if I have to go, I'll give her a letrozole induced cycle and then prepare her endo and do a transfer instead of going for
And
it.
in fact, if you're doing a modified natural or you're giving a stimulated cycle, complications like preeclampsia, complications like GDM, and so many other complications because of the corpus luteum are prevented. Because I do a lot of modified natural and stimulated cycles recently, I feel it makes a lot of difference, especially people who are doing obstetrics. It makes a lot of difference.
And endogenous estrogen gives a very beautiful triple layer. So
I
probably till the time a patient is ovulating, it is good to give them a modified cycle. That is what I try at my place is letrozole. And HRT I have reserved for those ones who are perimenopause or who are postmenopausal or post-POI, in which you don't have any other option. So till the time patient ovulates, it's always good to give them a modified natural cycle.
Point
That's
well.
that's what I do at in my practice too.
So in fact, there have been a few recent studies which also prove, the same, that I'll just share that, where the endometrial thickness preparation for HRT versus natural, but I think for all practical purposes, it's modified natural or stimulated, like how Sheetal said. So the biochemical pregnancy, so the pregnancy rates, implantation rates, live birth rates, everything was statistically higher, and this difference was statistically significant for natural versus HRT in this particular study. And not only like we said that because of the presence of corpus luteum and it also has higher endometrial thickness when you use a natural or a modified natural cycle as compared to the HRT. So the ET thickness also will increase with a modified natural thickness, modified natural cycles.
Plus, you reduce the pill load of the patient also.
Absolutely, yeah.
Patient is very happy with that.
Yeah, so now I think the most exciting and interesting part of the panel, I would like to know what are the strategies that you use, what are the adjuvants that you use in this patient. So she is a case of refractory endometrium, or even if it is just her first FET cycle, I'm sure all of us would want to use some or the other adjuvants. So which ones are your preferred and how do you use them? Whoever would like to, Dr. Bimal, would you like to take that?
Yeah, I mean, again, it's a mix of things that we use, but largely I'm very conservative about the use of these kind of supplements. So it's mostly estradiol and a little bit of vitamins and those kind of things, and aspirin in very select cases, and rest of the things I don't really use. I don't. I've tried sildenafil and those kind of things, but generally in my practice I don't use those things.
Okay. Sheetal? Okay, so yes, estradiol we have been using, all of us. I think GCSF is something that I was using since a long time. PRP, intrauterine PRP in some patients. Sildenafil, yes, I use in patients because I think it helps. Other than that, intrauterine PRP, subendometrial PRP is patients where there are refractory endometrium, when the endometrium is not growing. That has given good results in some of my patients. So that is what I have done, but that is selectively. Only one point, if I can add, chronic endometritis is something which is very common, which we miss on. I think especially we have a lot of laparoscopic surgeons here. So I was getting a lot of patients which were not getting pregnant, and I was not understanding what exactly is the problem. So TB is not the only condition which is a problem. A lot of patients have infection. You have to just send them for testing, and you just give them a course of antibiotics and they become pregnant. So just do a hysteroscopy. You'll see those strawberry pattern, whatever endometrium, and you give them a course of antibiotics and they become pregnant. And it is very common and very rampant in India. Especially you see these pouch of fluid in the endometrium. Yeah, Amog, go ahead.
Yeah. So first and foremost, before using any of these adjustments,
Do a hysteroscopy, yes. You have
Yes.
So of course. No.
Know the cause. What is the exact cause of
There
this?
you are muted.
So we
Amog.
And in endometritis, I would say not just a short course of antibiotic, give a long course of antibiotics so that we can correct the exact this thing. So I would prefer, if endometritis is there, give a long course, say 15 days of
Sorry for the disconnection. Yeah, so get a good ultrasound done by yourself with a 3D. You
That
can pick up chronic endometritis on ultrasound.
It is,
You
yeah.
do not require a hysteroscopy all the time. Get a good ultrasound. You can diagnose chronic endometritis. You can diagnose Asherman's, adhesions, micropolyps. All these can be diagnosed. Once they are diagnosed, then you do a hysteroscope to confirm your diagnosis. And always do remember, get 2 set of biopsies. One is CD56 and one is CD138.
Amog, why I spoke about chronic endometritis is what happens is that at least I was missing out on it. Like at least 5 years back when I started my practice, I was missing out on it and I was not understanding. And just by giving this course of antibiotics, I started getting it.
So now herein lies the importance of CD138 and CD56.
There are now
If you have one CD138 positive, even one, that is indicative of a chronic endometritis, which is because of an infection. But when you have a CD56 low light microscopy more than 6%, then it is an autoimmune or autoimmune factor or increased uterine natural killer cell. In such cases, steroids or prednisolone, maybe 4 milligram, 8 milligram before planning the patient for transfer can be given and also continued throughout the preparation and even after the transfer.
So,
So that
Amog,
is
do
the
you
important.
not do a hysteroscopy even if you suspect chronic endometritis on an ultrasound?
So you have to differentiate whether it is a infective endometritis or if it is an autoimmune endometritis. So in such cases, when you see signs of endometritis on ultrasound, go in with your hysteroscope, take a biopsy, send samples for CD56 and 138. And you can also send samples for BL6. So when all
Do we
three,
do that practically, or are we just treating it on the basis of what we see on hysteroscopy, basically?
so this is what I practice. I send each and every patient, I send samples when I see chronic endometritis.
Yes,
But what makes you say it is chronic endometritis, Amok? I just want
On
to ask if you
ultrasound.
are gone inside. No,
On
I mean, you
ultrasound.
said you will go on ultrasound. What are the things which you think that it is irregular endo low
No,
flow,
it's
and
not.
what do you?
There are these pouches of collected fluid in the endometrium. This is very typical of chronic endometritis. You'll see many patients, Ekika.
So you will
The
see
ones, so that's what I
endocervical
mean.
fluid,
On
you
if
will
you
see
see thin
endocervical
endometrium
glandular
or the
hypertrophy.
fluid in the endometrium, or even they have sometimes those cysts also, which
Yes.
are there, which
Yes.
can give us a hint that it is a
Chronic
endometrium.
endometritis. Yes.
One thing which I want to ask all of you, once you decide and do hysteroscopy for a patient who has a thin endo, do you have an itch to cut a lateral metroplasty or something like that? Does anyone do this with thin endo patients while you are doing hysteroscopy?
Yes, in some patients, yes, lateral metroplasty has given good results. Lateral metroplasty.
But for that you need to have a bicep uterus. Bicep cavity.
Scratch. I think it's not exactly a lateral metroplasty per se, but more like an endometrial scratch. You will expect that, you know, the blood flow and regeneration is
So-
slightly better.
So the principle is same as PRP.
Absolutely.
You are trying to
Injury.
induce growth factors by
Injury.
causing an intentional injury.
Injury.
Dr. Amrita, I just wanted to add one thing in my practice. I've seen one patient of refractory endometrium and she was not able to conceive. So I can find on ultrasound, there were some calcified small patches. When I did a hysteroscopy, I saw the chronic endometritis with some calcification over there. That is osseous metaplasia, where we find it, and we just excise that calcified area, whichever it was possible. And in my surprise, next cycle, I have seen the good endometrium. So this is the very important in our scenario. Like previous DNC or any MTPs or any medical termination, which the patient never mentioned, they have taken pills for abortion. And this can be a reason for refractory endometrium or thin endometrium.
Yes. Dr. Amog, I just want to ask one question to you.
Yeah.
What on sonography, according to you, suggests chronic endometritis? And also, when you do a hysteroscopy, how do you decide whether you want to send the biopsy for, you know, the CD?
CD56.
Yeah.
So slightly unconventional and not according to ethos. But I do hysteroscopies only when I see some therapeutic indication for a hysteroscopy.
Correct, which is fair.
Yeah. So on ultrasound, what you see for chronic endometritis is that you will see maybe some fluid accumulation right from day 5, day 6 in the endometrial cavity.
Correct.
And one of the most common factor that you see is a endocervical glandular hypertrophy.
Okay.
So the cervical region, if the cervical glands, which appear slightly hypoechoic, if it is more than 7 millimeters, it is definitely endocervical glandular hypertrophy, which is common in chronic endometritis. Thirdly, you will see a hyperechoic halo around the outer borders of the endometrium, and you will see poor endometrial blood flow, which will be not even be grade 1 or grade 2. So
Okay.
these are the signs which indicate that it is a chronic endometritis
On ultrasound.
on
Yeah.
ultrasound.
Yeah. Now, what do you see on hysteroscopy and decide whether you want to send it for biopsy?
So you see micropolyps, you see strawberry patches, you see congested blood vessels with stasis of blood flow. So if you are using a 2.9 millimeter hysteroscope, just do a contact hysteroscopy. If there is no movement of the RBCs inside the vessel, that means that is a thromboembolic disorder of the microvasculature, which is because of some kind of inflammation. So these are the 3 points I see before sending a biopsy, and I generally take biopsy from that side.
Amog, see, practically it is not possible to send investigations for all the patients because it is expensive. It is around 5,000 rupees what you're talking about. Personally, what I feel
I agree, but
whenever you see chronic endometritis, just give a course of antibiotics. Give them, anyways, you are going to give them steroids. You are anyways, most of the time when you do an FET cycle, you are going to give them a course of steroids. It doesn't cause any harm. It is anyways going to suppress immunity.
No, I beg to differ.
No.
If it is an autoimmune disorder versus a bacterial infection, if you give steroids, it will increase the infection.
I anyways, during the FET cycle only, not before the FET cycle, give steroids to each of my patients.
No. So even if you give antibiotics to all patients, and if it is
Not all patients. Not all patients.
Patients with chronic endometritis, right?
Yes.
Right. You give antibiotic to all patients. What if that particular bacteria is resilient to the antibiotic?
But more practically, it is not possible to do tests for all the patients. Is
Don't
what
do it for don't do
like
it
a
for all
debate
patients.
between Sheetal and
Yeah.
Amol. It's
See,
not possible.
but
Yeah, but I
patients,
agree with Sheetal that it's
And
practically
in small
not
towns, it
possible
is
for
not possible to do the testing also.
Mumbai
It's
small
not
town नहीं है.
available. It is not available.
Okay,
I'm just saying
okay. So
practically.
one point in favor of me, right?
Okay, how
5,000
many
rupees
people are
spend करना.
doing this testing?
I am not
5,000.
doing it for all the patients. It is
I'm
not
not doing
More would know.
Yeah, so 5,000 rupees spent karna is easier than having a negative cycle or cancellation of cycle.
That wouldn't, okay.
I want to
See,
ask you one thing. In chronic endometritis, will you see a blanched endometrium, or you will see those strawberry or bilkul
Hyperemic,
fire?
hyperemic.
It
Chronic
depends when you do
endometritis
it.
will
Yeah,
give you a very
It depends
blanched
what
and
do you do it.
Correct.
That strawberry pattern is very common, Ekika, in
The
chronic.
micropolyps also are very
Micropolyps
common.
also.
So if you do it on day 4 or day 5, if the patient has a bleeding period of only 2 days, 3 days, and you do it on day 5, day 6, you will see strawberry pattern in all patients.
Okay.
The correct time of doing a hysteroscopy for thin endometrium or chronic endometritis is between day 9 to day 11.
Once the bleeding stops, generally.
So you have enough endometrium to comment whether it is a strawberry pattern endometrium or is it just patchy endometrium post menstruation.
Post menstruation, that's true. And probably sometime when you are getting a very thin endo and a very blanched endo, that also, so it's all gone. I mean, it's already in a chronic endometritis state, which you generally see in cases of tubercular patients. It's absolutely poor prognosis, white blanched endo. So that is when, and yes, this is, I go with Amok's point, said spending 5,000 is better than not getting a result. So probably, yes, this thing, I mean, one should think of practicing when we really are sure that it is because of the chronic endometritis that we are not getting the results.
So we have an ongoing Indian study from Wardha.
Okay.
So in which all the patients are subjected to endometrial biopsy for CD56 and CD138. So it is being conducted at Sevagram. So and the results are due, I think, by next year.
Okay, that sounds good.
Do share with us so that
Sure,
we can know. I want to know how many of them are autoimmune, because autoimmune diseases are not very common in our country,
No, they
as
are.
it's common in
They are.
Western
As in,
countries.
surprisingly, they are more common than infectious.
Seriously, I mean, then we really want to know, because that's a normal notion that autoimmune disorders is more for the Western countries and infection is more for our countries. So probably this will definitely change some kind of a protocol if they are autoimmune.
Right. Vimal, your comments.
Yeah, so I do have a low threshold for hysteroscopy. I do use it for as a pre-IVF. I do it in most patients, and I don't send too many biopsies like you, Amok, but I rely on the visual thing. So if there is endometritis, definitely course of antibiotics makes a huge difference in the outcome. And another important point is there are some papers just by merely doing in the context of thin endometrium and absence of any obvious infections, just doing the hysteroscopy, the expansion of the uterus and then shrinking, even that there are papers saying it does improve some kind of the blood flow to the uterus. So
in fact, even the studies and the evidence states that of all the adjuvants that are options that are available, hysteroscopy is probably the only thing that has a beneficial effect. It's a beneficial intervention. The rest, some of them, like you can see, have an unclear effect, and some of them have no evidence of benefit, but we are still using them. But I also agree with Dr. Vimal that we should have a low threshold for hysteroscopy in IVF patients, because there may be a lot of
will let us know what exactly is the diagnosis also, I guess.
Absolutely.
Yes, what exactly is the problem
Especially
to
in
come
thin
to know
endometrium.
through hysteroscopy.
and even there some there are like papers talking about this hysteroscopy as a GPS. It helps in the transfer also, like how to navigate and put your catheter.
Yes.
Then I would like to
instead of
ask,
doing the mock ET, you do a pre-IVF hysteroscopy.
Yes.
I have a question for Amok sir. Sir, what do you do if a patient has been diagnosed as an autoimmune chronic endometritis? What is the treatment for those patients?
So I start her on prednisolone 4 milligram basic. Depending on her BMI, I increase or decrease the dose.
But
Okay.
Amok 4 milligram prednisolone is not going to be very effective if a patient is having definitely an autoimmune disease. The
So if
doses
it-
have to be pretty higher in those patients.
Yeah, so you can go as high as 20 milligram. That is what I said. That depending on the BMI, and secondly, if her CD56 is positive, then you have to investigate her further for other autoimmune disorders.
Yes, precisely. You
And
have to
if
first of all find out which kind of autoimmune disease
right,
she's suffering, and then design your
if she is
protocol
having
based on
any
that.
kind of polyarthritis or autoimmune disorder, you can
SLA
straight away,
is one which is pretty
yeah.
common.
So you can
SLA is
straight
one
away
which is
start it
pretty
on
common.
HCQ. HCQ you can
Yes,
start 3
HCQ
months
is pretty
before,
safe. Yeah,
3 months before the transfer cycle,
yeah,
continue it throughout the
throughout
pregnancy.
the pregnancy. SCQ and prednisolone can be given, and prednisolone in these cases you might have to start at the days of 20 or 40, depending
20 or
upon
40 you
the
can start.
depending upon the stage of the autoimmune disease.
Right.
And then yes, we
If
have
the
to add
ANA titers are
low
on a higher
molecular
side,
weight heparin in these cases if she is diagnosed autoimmune case.
so you can depend on your ANA levels. If your ANA level
Yes.
titers are high, then go for a higher dose of steroids.
Right. So does anyone have has used HCG for improving the endometrium, and how do you do that?
Yeah,
How-
so we generally do it if the endometrial vascularity, not the thickness. If the vascularity is on the lower side, then maybe on day 13 and day 14, we give a 200 IU infusion of HCG. We do not give a subcutaneous injection. We give a 200 to 300 IU of HCG. The reason being, one, it is stimulated when we insert the cannula just at the level of internal os. You are invoking some of the inflammatory response. Along with HCG, there will be increase in the growth factors, namely VEGF and IGF. And this helps in increasing the vascularity and the receptivity of the endometrium.
You're talking about FET cycles or any fresh or
FET cycle. FET cycle.
Okay, okay.
You can start it from day 7, day 8 also. You
Yeah.
can do a dose of around 150 IU, and that you have to continue. You can continue it up to the day of progesterone.
No. I'm not talking about injectable. I'm talking about uterine infusion.
I'm also talking about intrauterine injection only. Perfusion.
So there are two schools of thought. One is where you can give it subcutaneously for 7 days in an FET cycle, started from say day 8 of your after starting your estrogen, and give it till the day before you start progesterone for about 7
Even
days.
on the day of FET, there are some studies that even on the day of FET, you give it just before the embryo transfer, like 1 hour, half an hour before the
Yes.
embryo
The
transfer.
paper says 3
Yeah,
hours.
2 hours before the embryo transfer. Even I have not done that because I'm very scared, because I'm scared that what if it doesn't get absorbed. But then there are studies about that as well.
Okay. Sildenafil, practical uses, does everybody use it? Is it very commonly used in your practice? Anyone can take up this question.
I have been using it. I don't know how effective it is, but
Uterine vital Doppler, depending on that. Started on day 7, day 8. If
But-
your RI is above 0.91, start sildenafil. It does come down, not significantly, but yes, it does improve. The resistance index does go down to around 0.7 or 0.8.
you have to be very careful because a lot of patients get headaches post sildenafil. So you have to be very careful when you are giving sildenafil.
If the patient does not tolerate orally, you can give vaginally, but the downside of vaginal is that
Most studies do.
Most are giving I am giving
vaginally.
But the downside of vaginal is when you do an ET, you see a very eroded cervix, external os. That is because of either the effervescent or even the tablet staying there, becoming like a ball.
Okay. PRP, which is not exactly new kid on the block, but it has been used for so many indications, and now we are using it for thin endometrium as well. So again, anybody who would like to take this question as to what is the practical use of PRP in thin endometrium, and how do you use it? Do you give it as an intrauterine infusion, or would you prefer giving it as a subendometrial injection during hysteroscopy?
See,
In the HRT cycle,
Yeah, go ahead. Please go ahead.
in the HRT cycle, I'm giving it as intrauterine installation on day 7. And then after about 48 hours, I monitor. If it is not up to the mark. If the increase is not up to the mark, then I again give it. And then around after 2 days later, when it has reached more than 7 mm, then we start the progesterone. So usually 2 PRPs are not needed. Mostly the patients respond to 1 instillation of PRP.
So what would your criteria be for to start a patient, like to for a patient to give a PRP installation?
Endometrium, if the endometrium has been less than 6 mm in her previous cycles.
And this
monitor.
is what you would do routinely for all patients of thin endometrium, or is it?
Yes, for all patients of thin endometrium.
Does anybody want to differ or has
I
any
think,
other?
especially in refractory endometrium, I prefer doing, as I spoke to you in the beginning, I prefer doing this subendometrial PRP installations, and especially endometrium not growing beyond 6 millimeters, 5 millimeters. In those cases, I think subendometrial PRP has really helped a lot. And preferably the preparation of PRP also matters a lot. So I think people most of the time just use the centrifuge, do the PRP, but I think activation of PRP is also something which matters a lot. So I think now there are kits which are available, and try to use the good quality PRP, because what happens is when you centrifuge, the amount of PRP that you get is also not enough when you are doing the subendometrial PRP. Subendometrial PRP, you have to do it in all the walls. You have to do it in the lateral walls. You have to do it in the anterior wall, especially in the fundus, everywhere, posterior wall. So for that, you need a good amount of PRP. So try to do it with a proper kit. And then I think only then you will get results, because if it is not activated, you are not going to generate growth hormones and stuff like that.
Yeah, actually, 15 to 20 ml of blood that you collect will give you only 1 ml of PRP.
Exactly.
You require 60 ml of blood.
Yeah,
So
you
the
need to
kits,
take
the
60
kit
ml of
says
blood
it has to
get.
be 60 ml of blood.
Yeah.
The kit has a proper injection,
It's
and the most important thing that most of us don't follow when we use a centrifuge is just sterile condition of the PRP.
Absolutely, and it's going to cause
Because
more
when
infection
you
and
do,
more problems.
yes, so when you do a subendometrial injection with a such poorly prepared sterile condition PRP, it is going to cause more harm than good. Now,
And especially, I have also been doing a lot of intra-ovarian PRPs. I think it has made a lot of difference, because I am using this activated PRP and it is showing a lot of difference. So use of proper PRP is important. Just doing PRP is not going to help either, whether it's intra-ovarian or intra-endometrial, subendometrial.
another important thing is PRP once prepared should be used within 2 to 3 years max.
Yes.
So it should be a freshly prepared PRP. ये नहीं कि lab में भेजा है, एक दिन बन के ready है, and then you get it the next day. It is not going to work. And another important thing about PRP is that the site of injection has to be subendometrial, not endometrial, not myometrial. It has to be subendometrial. If you go myometrial, it is not going to give you good effects. So that is very important.
Point taken. Yes.
And you do that with the pickup needle, right?
No. So
How
I
do
do
you
it.
inject it? Yeah.
So I use cyst aspiration needles which radiologists use. So it is a 18 gauge needle, just like the OPU needle, but it has got serrations and markings. So you do the measurement of the endometrium and you look at the markings, and yes, you have the tactile feel when you inject it, but the marking does guide you as to how much the needle has to be pushed inside the endometrium so as to reach that that sweet spot of endomyometrial junction.
Okay.
So that is what I use. And another
How much is it on an
advantage of this
average?
cyst aspiration needle is you can use a 3-way.
Okay.
So there is no regurgitation of the fluid while you're doing the injection.
Right. But how much depth do you need to go with that needle usually after you measure?
So there are measurements of 5 millimeters.
Okay.
So generally when you have a thin endometrium, it is hardly 5 or 6 millimeters. Especially on day 6, day 7, day 8 of the cycle, the endometrium is thin itself. So you have measured your endometrium on ultrasound, only the one side, not the entire endometrium, just the one side, half the endometrium. That is the thickness.
Yeah.
And then that the graduations on the needles guide you as to how much has to be inserted.
I think that is something which, if you have it, it is okay. I think if it is not,
It is cheaper than egg collection needle.
I'm
It
just
is
saying,
200
if it's
rupees
not
needle.
available because everybody might not have an access to it, I think a pickup needle is also good enough because it goes through the hysteroscope channel also easily.
Exactly.
So you can
And,
just
and you
put that
can
and
measure your you can measure your ET.
Okay,
and
so let me just help everyone out. Any person who sells an IUI cannula has this cyst aspiration needle. So wherever you procure a IUI cannula, just ask the person, give me a cyst aspiration needle, you'll get it.
Thanks, Amol, for that tip.
Good idea, Dr. Moore, for the marking. Because sometimes when we are doing with the ovum pickup needle, so when we are injecting and after that we decrease the pressure and taking it out, the fluid is coming back.
It comes inside the syringe.
Inside the cavity. So that's a disadvantage of doing with.
Opening needle.
Yes.
So when
But then, intrauterine infusion is also done. So by that logic, it doesn't really, I mean, there is no
the purpose of injection is limited.
Hysteroscopy, we are using fluid. So it's very common to come out with the fluid.
Yeah.
Because generally you keep the pressures, even if you keep the pressures at 100, either
it
there
is
is not
going to
enough
ooze out.
distance.
See, because the pressure is high, even if you aspirate or it comes out, it is going to ooze out. That is what I feel.
No,
Oozing
it doesn't.
is
It
high
doesn't.
here.
If it is in the proper channel, it will not ooze out. So, okay.
When the pressure is going to reduce, Amog, when the pressure
Sorry?
is going to reduce, don't you think it is going to ooze out?
It won't ooze out completely.
Not completely, obviously, because you're going into the subendometrium, but it does.
Right. So there's a good paper, wonderful paper by Dr. Meenu Agrawal from Pune. I'm quoting all Indian studies because that is what is pertinent to our patients. So it's a case, it's a retrospective study of I think 36 or 37 cases. And in that, she has achieved a good pregnancy implantation rate after PR.
I know. So PRP is definitely something that we can use, even though evidence may state otherwise. But I don't think we should refrain from using it just because of that.
But if you are going to use it, use, as Dr. Sheetal said, the activated one.
Use it correctly. Yeah. Okay, so this is for the endoscopic surgeons in the panel. Of course, we do have a role of, there is a definite role of hysteroscopy in evaluating thin endometrium. Any tips and tricks for adhesiolysis for Asherman syndrome? Dr. Beeman?
Yeah, so Asherman's, again, you do try to diagnose pre-op, so then you can plan your hysteroscopy accordingly. And always use scissors. That's the first and most important point. And depending on the grade of the adhesions, it can get very challenging. I think Dr. Sudha ma'am was also talking about it. So simple adhesions, it's relatively straightforward. Cut in the middle. And if you can visualize at least one ostia, that should be your landmark and that should guide you to the other side. And there is also now I've tried using, while cutting the adhesions, trying to use concomitantly ultrasound. So, that kind of, helps a lot. So, and also, the fluid behind the adhesions that actually is more visible on the ultrasound. So that also guides you where to cut and once you cut those adhesions, the fluid, gives way to the adhesions and makes the job a lot more easier. So
that's very
tough
important.
cases, you can use ultrasound.
Yeah, that's a wonderful point. Even I've started using recently because no matter how many cases of adhesions you have done, always there'll be one case where you will see nothing.
Yeah.
Right, absolutely.
So what exactly do? You do the ultrasound, like the abdominal ultrasound, and simultaneously.
So one of your assistant would be holding the ultrasound, focusing the uterus in sagittal or a coronal plane or a transverse plane.
Okay.
So if you have a 3D, all the more better. If not, even a 2D sagittal works.
Right.
Yeah, 2D is good enough, but yeah, it really helps.
Especially, I think at locating the myoma, also a lot of people use it, right?
Yes. For that, you can
For a laparoscopic
vaginal sonography. Yeah, for a laparoscopic. I think for a laparoscopic. Yeah, that's right.
Okay. Any other tips and tricks, Dr. Amok, if you would like to add?
For Asherman's, generally, what I do is follow the blood flow. Many times in Asherman's, you do not have a blood flow. But when you see a blood flow, try and follow it and try cutting it. Give small snips. Don't be too overzealous and just keep on cutting randomly wherever you feel that there is a cavity. Because many a times the uterus might be just in a normal position of anteversion and anteflexion. There can be a dextro rotation, there can be a levo rotation, there can be a retroversion, there can be a mid-post uterus. And what you think is the central axis might actually be, you might be cutting into the myometrium and into the posterior wall and then injuring the intestine. Although hysteroscopy scissor doesn't cause that injury, but if you're using a resectoscope, then
But
you
when you say when you're cutting and you're getting blood flow, it
No,
means
he doesn't mean the myometrium blood
Myometrium.
flow. It's the, the cavity.
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 When you see
Like the-
good blood supply,
Yes.
you won't see a good endometrium, but you will see some pinkish tissue.
Correct. Yeah.
So in between all that white, fibrous, dense tissue, if
Yes.
you see a small segment of live tissue, that
Exactly. And
endometrium
that
is
was shown, that was also evident in the
yeah. So
video
I think
that
the one you did,
yes.
the one you did, it was
Exactly.
what you should do.
Yes. Yeah. All right. I think we've covered this extensively, chronic endometritis. Just one question, is it indicated for all pre-IVF hysteroscopy? Yes or no? All of the panelists?
No.
No.
Not indicated, but I do it.
Yeah, actually, practically, what do you do?
Yeah.
I do it.
Do.
Don't want to fail our IVF cycle and then retrospectively doing hysteroscopy and then second attempt. So it's better to do before practically.
All right. Okay.
So I have one question with Amog. What do you do for the hysteroscopy, the sampling for the tuberculosis? With either you're doing
TB PCR. We send it to a government center. It is free of cost. To the patient.
So it's showing 100%.
Can I say something? Can I say something?
Yes, sure.
So nowadays, TB PCR has given way to CBNAT, and CBNAT is being done free of cost in all the government centers. So what happens is, like in AIIMS Bhopal and in GMC Bhopal, the CBNAT testing is not done, so they outsource the collection and the testing is done, but the collection is not done. So you simply become that Nikshay Portal Yojana. You go to www Nikshay portal. We did a big FGTB webinar with JB Sharma sir from AIIMS Delhi. So all of us became Nikshay portals. So you just go to Nikshay portal and become a Nikshay center. So they'll come and collect the CBNAT thing, and it comes. Just now I got the report of my patient. I sent about 2 days back. So it has come on my mobile.
Oh, that's
How reliable is it, madam?
It's
See,
very
there is
reliable.
no other way. There is but now the FGTB guidelines. Please read them by JB Sharma, and please watch my webinar on FGTB. We have done an excellent job. I mean, I'm not boasting, but that webinar opened my eyes to FGTB in a big way. And Professor GB Sharma was with us for 2 hours talking. And Purnima, my coordinator, she has done a case study on tuberculosis in AIIMS Bhopal. And she also told me everything about CBNAT and everything. So it is very reliable. But if in case your test is negative and you've got positive imaging findings related to ultrasound or to endoscopy, then also you can start ATT, but you have to notify on the portal. And every patient will get all the medicines free of cost, plus 500 rupees per month for meals, nutrition.
Ma'am, because TB PCR is generally not reliable because
No,
lot of times
TB
it is not.
PCR.
Yeah, so that
a
is
strict
what.
no.
So
There
what
are only
exactly?
4 tests. One is CBNAT. Second is histopathology for granulomas. Third is staining, gram staining for AFB. And fourth is your endoscopy findings.
Yeah.
Ma'am, apart from this webinar, unmarried girls, they are having secondary amenorrhea, and we can see on ultrasound it's a thin endometrium, and it's being amenorrhea since 1 year. So what do you suggest to this patient to how to diagnose
No, first you take a history. This usually a tubercular patient, you know, in 20s will have some history of contact in adolescence or in childhood. They will give some history of a nodule, neck gland.
No, ma'am, nothing.
Draining sinus.
Nothing, ma'am.
If there's, it's not that you try withdrawal. If withdrawal happens easily, yeah. If it is refractory thin endometrium, then you have to treat on lines of tuberculosis. Then you put a scope or something. If the patient is not
You
able
can
for
put a
scope,
1.9 millimeter scope for such a patient.
yeah, yeah.
Without compromising the hymen. And
You
it
know
goes
what?
very easily, and you can see visualize it very nicely. Take the biopsy, send it for CVNAT.
The sad thing about FGTB is the endometrium is the tubes and the endometrium are affected earlier, and by the time you get the TO mass, it is too late.
That's what.
Right.
You know, so the early
Don't repair
stigmata are tubal and endometrium.
Endometrium.
Yeah, and the ovaries are
Hmm.
affected last.
Late.
So by the time you are seeing the TO masses, tuberculosis, it's absolutely no use. You know, then you have to like basically then do all the salvage therapies, GCSF, PRP. And I mean, listening to Amok, I was doing my IUIs, but I was listening to Amok. He is so brilliant with this needle thing. Cyst aspiration needle, तुम नागपुर से भिजवा दो भाई.
बिल्कुल मैम भिजवा देता हूँ.
Ask for
Whenever I go to Nagpur, I'll collect from your center.
मैम अभी इसार में दे देता हूँ.
हाँ, right.
Probably patented and like patented for reactive.
Yeah.
Monica, ma'am,
Yeah.
my patient, she's still 17. I've started empirical AKT for her, but she's not responding. So what next then? Like she's 17.
If it is Amok, tell me, agar basal endometrial damage hai, refractory, then probably you can't do anything.
You can't do anything about it. If it's a young age, maybe pre-adolescent or pre-pubertal, agar hua hoga, then it will be a completely destroyed basement membrane.
It is a bacillus. The bacillus is destroyed. You know, there's functionalist layer and bacillus layer. If the bacillus layer is gone, then probably you can't do anything about it. And probably then just put a scope, see for patches. Wherever there's a pink patch, you put some PRP. Try GCSF.
She's only 17.
So here is the role of bone marrow stem cells.
Stem cell.
So
Yeah,
not
so-
now, but maybe in a later stage, once she is sexually active or once she is married, you
Then-
can reevaluate her and
Now, my question is, how long should we continue with the AKT? This is my question.
6 months, 6 months.
6 months, complete 6 months.
Endometrial tuberculosis is 6 months, 2 months intensive phase, 4 months continuation phase. That is it. Only if it is extra pulmonary and other FGTP is not counted for 9 months. But 9 months therapy you require for defaulters and for other stigmata, like she's got bowel involvement also, or she has got some multi-system, or you have got some history, of nodes or something. Then you can carry on for 9 months. Then there is this for MDR, they have got different protocols. It's such a beautiful article by JB Sharma. आप लोग सब आज रात में ही पढ़ लो. It's really beautiful. It will open your eyes. I mean, what a person, yeah. We've got such gems in India, and we know so little.
True,
We know so little.
Thank you,
My
ma'am.
children are forever complaining, Mama, you're reading all the time. Manika, despite reading all the time, I don't know anything.
Exactly.
You're an
As
inspiration for
Dr. Rishima said.
yeah.
Yeah, so you people have a long way to go. I mean, you people are brilliant. You've got all that, leverage. Amok has got, Amok, I listen to such a lot of good things from Pragati about you, Amok.
Thank you.
And you people are doing so good, or Amrita, Aditi. I mean, you people have such a long way to go. You inspire us. We want to emulate you in your work, in your procedures. We want to ask from you.
So I think
So that's a great job done. Are we over with the panel?
yes, we're over with the panel.
Yeah, so thank you so much. Tech support, can we have a combined picture? And yeah.
I'll just stop the screen share.
Yeah, sure.
Yeah, and then we can.
So I hope you all enjoyed ISAR Perfection. That is how we...
Best luck, Dr. Monica. Best
Thank
luck,
you
Dr.
so
Ranveer,
much.
Dr.
Thank you so
Ritika.
much. Thank you so much. But I told
Just
you,
2 days to go.
whatever be the result, we'll keep doing this. We'll keep working with the ISAR team, and we'll be, doing a great job together like this. And let us all stay connected. Sheetal is there, and Sheetal gave some brilliant answers. Supriya, Achal, Dr. Bimal, I'm meeting for the first time. Ekika, of course, and Kalpana ma'am. I mean, you all were fantastic, Sonali. So let's just connect and solve our doubts, solve our queries. There's always some good thing one person can tell another person, and that is all these online and off-site conferences are all about. Okay,
Thank
so
you, everyone.
Thank you,
thank
ma'am,
you,
and all
Thanks,
the best.
Aditi. Thanks,
Thank
Thank you,
Amrita.
everyone.
It
Thank
was
you.
nice chatting
the
and
best,
talking
ma'am.
to all of you.
Thank you,
Bye.
thank you,
Best
thank you,
luck.
Intas.
Best luck.
Thank you, Dr. Vishal. He is
Thank
my,
you.
he's
Bye.
our backbone. Dr. Vishal Dave is the person who does everything, he does a webinar in 24 hours.
That's
So
Thank
Ranveer,
you, ma'am, and all the best to all the candidates. All the best,
All the
ma'am.
best.
All the best, Ranveer sir.
Ansel and
Best luck, everyone. Bye.
Thank
Take
you.
care.
Thank you,
Bye.
sir. Thank
And
you.
see you
Bye.
all at SR
Yes,
with
Yeah,
Neshwar,
yeah.
and
Yes.
Bye.
Yeah.
let's celebrate our SR Day.
Yes, yes, yes.
Monica,
Thank
ma'am.
you. Thank you. Good night. Bye. Bye.
Good night. Bye bye.
Thank you.